Good morning and welcome. I'm Oxiris Barbot, and it's my pleasure to welcome you to United Hospital Fund's Medicaid Conference. I am president and CEO of the organization, and I am thrilled to say that this is my first Medicaid conference. It's the organization's 15th annual, which is really awesome. So we're delighted to have you here with us, and we're delighted to be able to offer this in hybrid today. It's great to see so many of you in this amazing building, and a warm welcome to you all who are joining us online. I'm sort of looking for the cameras. I guess it's all the way back there. We're excited for a day of stimulating information about what's top of mind in Medicaid, as you will hear from Amir Bassiri, our Medicaid director, as well as challenges and opportunities within Medicaid for some of the most pressing issues in healthcare, addressing the ongoing opioid crisis, centering primary care, and integrating health and social care, as you will hear from our panels and afternoon keynote. And I'll say more about this a little bit later this morning. For those of you that are new to UHF, we are an independent nonprofit organization established in 1879, working to build an effective and equitable healthcare system for every New Yorker. We work towards that mission through research and policy analysis, hosting fellowship and demonstration programs, and convening diverse stakeholders to find common ground for solutions to pressing challenges in healthcare. At UHF, we focus on three critical areas in our healthcare system: expanding coverage and access to care, improving the quality, equity, and efficiency of care delivery, and addressing health disparities by fostering collaborations between healthcare system and community partners to address the broader determinants of health. Our Medicaid Institute, which was established in 2005, is in our coverage and access focus area. It's been working to strengthen and improve New York's Medicaid program through research and policy analysis, as well as convenings such as today's conference. And there is tremendous value in convenings like this one that bring together such a diverse group of stakeholders across state and local government, healthcare delivery systems, providers, community-based organizations, academics, policy experts, and Medicaid members. The opportunity for innovation and idea generation furthers our collective goal of strengthening and improving the New York Medicaid program. Also, based on last year's success of this conference, we've waived registration fees for those joining us online and for many attending in person, including Medicaid members, students, our colleagues in state and local government, and others. It remains a goal of UHF to increase access to this convening. Achieving this goal was only possible because of the generosity of our sponsors, particularly Unite Us, if we can give them a round of applause. Who ensure that the costs of the virtual conference were covered so all of you attending virtually could do so at no cost. I want to give a shout out to our lead sponsors, the Commonwealth Fund, a private foundation whose mission is to promote a high-performing healthcare system, and Unite Us, who brings sectors together through technology to ensure people's needs are met. You'll hear from the Commonwealth Fund shortly and Unite Us this afternoon, but I encourage you to visit their websites to learn more about their work. And of course, a sincere thanks to our other sponsors as well: Essentra Health, Find Help, Nice Tech, Public Health Solutions, the New York Academy of Medicine, and Big Apple Event AV. Of course, A conference like today requires the work of many. A big thanks to the amazing staff at UHF, including, and I'm going to say this in alphabetical order, James Andrews, Kathy Arnst, Emily Arson, Denise Arzola, Giovanna Braganza, Alex Brandis, Hillary Brown, Adam Fifield, Joan Guzik, Hollis Holmes, Amy Lynn, Susan Oliveira, Anna Quinn, Emily Regas, Joey Rodriguez, Sally Rogers, Chad Shear, Amanda Williams, and Sarah Wiley. If we can give them a round of applause. And just a few housekeeping things before we get started. One is we encourage you to ask lots of questions during today's session. If you're in person, there are mics at the aisles. If you're online, please submit your questions in the chat box. We will be fielding questions from both locations. Two, we want your feedback. For those of you online, there will be a Zoom poll at the end of each session. For those of you in person, you can access the survey through the QR code projected on the slides. Please fill these surveys out to help us plan for next year's Medicaid conference. And third, please share what's happening today through your social media. If you're on Twitter, start by following us at UHF, at United HOSP, HOSP Fund on Twitter. And then you'll see a tweet this morning with the conference hashtag UHF Medicaid 2023. Finally, I'm going to hope that as you leave today, you're going to be wanting more. So please be on the lookout for registration information for our November 1 Research Symposium. This is our annual research conference produced in collaboration with the Greater New York Hospital Association. And each year, this symposium highlights some of the great health services research being done in New York. I want you to submit an abstract if you're interested. The deadline for submission is August 4th, and instructions are on our website. So, and there you go, you've got your QR code. It's now my pleasure to introduce Melinda Abrams, Executive Vice President for Programs at the Commonwealth Fund, one of our lead conference sponsors and a consistent supporter of this conference for several years. She will be giving a few welcome remarks on behalf of the foundation. Melinda, please join us.
Good morning. Okay. Thank you, Dr. Barbot, and thank you so much to the United Hospital Fund for hosting this and convening this. And I have to say, I am amazed and overwhelmed and impressed with the number of staff people. It's really fantastic. And thank you all to all the staff people who put this together. I also, UHF plays such an important role as a reliable source of policy research and data analysis, as well as also for convenings like this. I want to also acknowledge my co-sponsor, Unite Us, and as also some of the other partners, but particularly the New York Academy of Medicine for, again, hosting this event. So Dr. Barbot mentioned that the Commonwealth Fund is a national foundation, but we are based in New York, so we have, a special place for New York. And although we are national in scope, as she mentioned, we're dedicated to, improving health and healthcare for everyone through a high-performance health system. But I guess what I wanted to just quickly say is why we're funding this conference. And I think it's really, I wanted to emphasize 3 reasons. So the first is that states are at the forefront of designing and redesigning U.S. health policy. From whether it's insurance or advancing equity or increasing affordability, states are often leading in telling us and showing us what to do. A current example that is I think the number one health policy challenge facing us at this moment is the unwinding of Medicaid's continuous coverage requirement. Choices that different states are making will affect how many people lose access to health insurance coverage. And then even within a state, it's choices about messages, choices about outreach. So just an example of so the first is really state-based conferences are so important. The second is Medicaid. Medicaid is a key lever to spark delivery system transformation. States and state Medicaid programs are leading the way in addressing, for example, the drivers of health or the social determinants of health, whichever term you want to use. Integrating those health and social services, and Unite Us actually helps with a lot of this with the number of states around the country, to help meet Medicaid beneficiaries and people's basic needs around food, housing, safety, personal safety, transportation. State Medicaid programs have also been at the leading edge for primary care transformation, whether it's payment, behavioral health integration, interprofessional consultation. And the third reason is, and Dr. Barbot mentioned this, is the power of convening. Bringing together diverse stakeholders to advance innovation that result in evidence-based decision-making. And that's what we aim for. That's what we're striving to do, is kind of equipping policymakers and leaders and all the stakeholders with evidence and to make informed policy decisions. That said, what I really hope for today and today's conference is that we look beyond the data, we look beyond the policy proposals, because it's not just a statistic or a waiver or a statute or a reg, it's somebody's life. And I know we all know that, and I know that's what we strive to do, and that's why we're here. But it's about someone who lost their health insurance due to some administrative hiccup with unwinding. It's about someone who died from a preventable and treatable cause because they didn't have timely access to substance abuse treatment. It's about someone who doesn't have access to primary care because our workforce is burnt out and demoralized. It's someone who is suffering from the staggering cost of medical debt. And I'm happy we're here. I'm really pleased that we're here, and I'm honored to be funding a convening like this. But I'm also suggesting that we don't just listen with our data brain and our policy brain, but that we also listen with our heart. If we've learned nothing from the pandemic, we learned the importance of designing and implementing policy with compassion and with empathy. I can think of no better organization to convene us than the United Hospital Fund. I can think of no better state in which to have this conversation than in New York, because of its history in terms of leading and in transformation and delivery system reform and insurance reform. And I can think of no better topic to bring us to this table than Medicaid, since it is the largest program in the United States with the greatest promise, the greatest challenges, but the greatest promise serving the most vulnerable Americans, and here, the most vulnerable New Yorkers. So thank you all for coming. Thank you for being here. Thanks to United Hospital Fund. And I'm going to turn it back over to Dr. Barbot.
Melinda, thank you so much for those inspiring remarks. I think it was really spot on in terms of reminding us to meld our brains with our hearts and to lead with our hearts in this important period of time. So thank you for that. As most of you are aware, enrollment in New York State Medicaid programs soared because of policy decisions that prioritize keeping people insured over verifying eligibility during COVID. As a result, the uninsured rate across our state reached record lows at helping New York achieve a longstanding goal of reducing the uninsured. A critical component of that low uninsurance rate is record Medicaid enrollment. Over a third of our state's population is enrolled in Medicaid, 7.9 million New Yorkers. And with the federal unwinding of the Public Health Emergency Declaration and a reversion to the status quo of federal requirements, including annual eligibility verifications, our state is presented with challenges and opportunities to remain at the forefront of progressive policies that center keeping people covered and connected to usual sources of care that maximize good health outcomes. We'll hear more about these challenges and opportunities from Amir, along with his thoughts about what our collective role is in this important area and what it should be moving forward. UHF has been proud to collaborate with our state partners and community partners across the state by hosting a convening in February that brought together just under 500 groups to discuss ways in which we could collectively contribute to minimizing the number of people that lost coverage due to the recertification requirements. And we are pleased that we will be hosting another such convening, likely at the end of August, so stay tuned for that. Another COVID-related policy decision prioritized access to treatment over stigmatizing people with substance use disorders, SUD. The changes improved SUD treatment and care by expanding access to medication-assisted treatment, or MAT, which is the gold standard treatment for people with SUD, by expanding the number of providers who can offer MAT, allowing MAT via telehealth, and increasing the number of days people could receive prescriptions for treatment, increasing the number of days that they could receive medications for, increased treatment engagement, patient satisfaction with improved care, and there were a few incidents of misuse or medication diversion. These policy changes expanded access to treatments during a drug overdose crisis due to fentanyl that likely will have had much more devastating consequences without these policies focused on expanding access. Given the success of these policies, many of these have been implemented permanently, but many challenges remain. The panel later this morning will discuss what we've done and what more we can do to prioritize access to treatment over stigmatizing people with SUD. And while this is a topic that could be at any public health or health insurance conference, it is of particular importance to a conference focused on Medicaid, because although people of all socioeconomic groups have SUD, people on Medicaid are overrepresented in overdose deaths across New York due to issues related to poverty and structural racism. And when we think about structural and economic barriers in access to care that cause significant harm, we must also consider primary care. Primary care was critical to the COVID response, but saw less innovation in terms of policies to improve patient access, provider capacity, and provider well-being beyond telehealth expansions. The literature tells us that having a usual source of care reduces ED visits, provides more comprehensive preventive care, is more patient-centered, and achieves better care for chronic conditions, including behavioral health. As we work to get people back into care and catching up with screenings and routine care, we need to continue to make innovative policy changes if we want to reduce disparities. Our panel this afternoon on primary care will talk about what innovations would help to improve patient care for children and adults with Medicaid. And to continue the innovation theme, at the end of the day, we will hear from Camden Coalition's Kathleen Noonan. Kathleen will describe their success in delivering health and social care to people with complex needs by developing ecosystems of care. As incorporating social care needs into Medicaid's care delivery in New York is a key element to the 1115 waiver that Amir will be speaking to momentarily. So learning about Camden's successes and their ability to measure that success will be of critical value to all of us invested in the ongoing and future success of Medicaid in New York. So with that as a setup for the day, it's my honor to introduce our keynote speaker, New York State's Medicaid Director, Amir Bassiri. Amir is a social worker by training and is a tireless public servant. After working in the nonprofit sector, he joined our state government 8 years ago, first in the governor's office and then transitioned to the Department of Health in 2019. As I've worked with Amir in my new role, I can tell you all how fortunate we are to have a person with his dedication and integrity leading our Medicaid program. Amir, welcome.
Thank you, Dr. Barbot, for the very thoughtful introduction, and I am very thrilled to be here and excited to give everybody an update on some of the transformative delivery system reform initiatives and other efforts that we're working on in the Medicaid program. But I do want to start with something Melinda shared and Dr. Barbot mentioned, which is a top priority for the Medicaid program right now and for all of us, which relates to the unwind and the public health emergency. All of the things I'll talk about with respect to the waiver and investments in services don't matter if people don't have access to those services and don't have coverage. So I do want to start with the unwind, especially given some of the news that you may have heard yesterday from the Center for Medicare and Medicaid Services, where they have directed 19 states to halt procedural disenrollments. I am proud to say we are not one of those states, but it does really ground us and humble us to know how important it is, and the next 12 months are, to ensuring that we sustain all of the benefits and gains that we've made over the last 3 years in perpetuity, and we can leverage all of the investments to support those members. So what I'll talk about today, I'll start with the unwind. I will give an update on the timeline. Proud to share some preliminary data from the first cohort of renewals, which is still in process. It is preliminary, so the numbers will only get better, is the good news. And I'll talk about some of the things we're doing to add additional flexibilities, keep people covered, make it easier to reduce churn in the program, and then move into the 1115, which I know there's a lot of interest about, give an update on where things stand with the negotiations with CMS and when we could expect an approval and some detailed descriptions on the current elements and framework of the waiver, and hopefully have time to give an update on the enacted budget, which has a lot of investments that complement what we're doing under the 1115. So this is just acronyms. I'm going to skip this for now. It will be helpful later on, I promise. So where are we with the unwind? We are in the midst of renewals and resumption of normal eligibility determinations. The PHE ended in April. States have 14 months to complete the unwind. New York is taking all 14 months, and we have started later than some of the other states. Our first renewal cohort had coverage end dates of June 30th. We will know the outcome of those renewals at the end of this month, and we'll share an update on what we're seeing thus far. The news is, we're cautiously optimistic, but there's significant work that needs to be done, and I'm grateful for our staff, who is equally as dedicated as I am to this, and will not rest until we get through this process and ensure that everyone who is eligible retains coverage. This slide is really intended to show you the complexity and the magnitude of this endeavor. We are trying to redetermine 9 million people's eligibility across a range of public health insurance programs across 3 different eligibility systems, all of which have different functionality and capability to, streamline the process for our members. They have different timelines. We're improving essentially the integration on the WMS system, and NISO is reporting out, and so the data I'll share really does show the totality both for all those systems and where we are. So if you heard or you were here last year, I made a commitment that the Medicaid program would be putting out a lot of information and being transparent about how renewals are progressing. And I'm pleased to say earlier this week, we released an unwind dashboard that is on the New York State of Health. It's on the Medicaid program website. We did a press release, and it shows a preliminary snapshot of where we are with that first cohort of renewals. Where things stand is we're about 72% renewal completion across New York State of Health and the local districts. We're not satisfied with 72%, but I will say, as compared to what you're seeing across the country, we are definitely doing much better than many other states. And this is somewhat evidenced by what CMS recently decided on yesterday to halt procedural disenrollments in 19 states. Why have we been successful, or why have we seen some success, is really related to all of the things we're doing to make it easier for members and for districts to keep people covered and reduce churn. And when I say churn, I mean people who are eligible for Medicaid or one of our public health insurance programs, but who lose coverage for procedural reasons. They didn't sign one aspect of one form or fill out one box that was necessary. We are doing everything in our power to prevent those types of disenrollments. The data that has been shared from other states is pretty concerning. 3 million people across the country have lost coverage. We are not even halfway through this process. So it is incredibly important, and we need the support of all of your organizations, all of our partners. This is all hands on deck to ensure that we're successful. We have taken advantage of several flexibilities that the federal government has offered. I'll go into those a little bit later. We are still in pursuit of new flexibilities to make it even easier. And we are working with federal agencies, federal partners, to see if there are other things we can do, workarounds, to prevent any procedural disenrollments from occurring through this process. So the snapshot of the data, I'm showing here something that is available on our website. This is our monthly unwind dashboard. Our team across New York State of Health and Medicaid have worked incredibly hard to create this report, and we're going to update it monthly, and this is the first iteration. As I mentioned before, it is not complete. So individuals in that first cohort still have time to renew their coverage. They have until the end of this month. We're at 72%. We expect that number to go up by the end of the month. We're tracking and reporting out data across various areas. We're stratifying, we're showing by age band, race, ethnicity, region. We want this data to be out there really to inform everyone and to target outreach efforts to make sure that everybody knows what is happening and how to access help. What we're seeing in the early data suggests that younger adults, those between 20, 34, are unaware of the changes that are taking place. We are going to use this data to continuously improve our outreach and marketing strategies, and I'll talk a little bit about those. But thus far, the data is encouraging. CHIP renewal rates around 77%. EP, Essential Plan, is a little bit lower, and Medicaid is around 72%. We are doing administrative renewals, which means very low impact to the member, and we hope to increase that administrative renewal rate as we go through this process. Why have we been successful, or what makes New York unique, is the way I think about it, is really centers around our assister program. Many states, expansion states, do not have an assister program. We have a robust assister infrastructure, and assisters really are individuals peers who are trained to help people get enrolled or get connected to assistants to get enrolled. And we've built out a robust infrastructure to do that. We have over 5,000 assisters across these three assister types, and they really are comprised of your organizations, healthcare providers that are getting trained by our staff and helping boots on the ground get people covered. 77% of people enrolled in the marketplace have gotten assistance through one of our assister programs. This is a really powerful statistic, and it's really a credit to many of you in the room. And the point really is that we need everyone's help to ensure that people don't fall through the cracks. We are doing multiple trainings for the public to get more assisters enrolled. We're doing provider trainings, provider webinars. As Dr. Barbot mentioned, we're working with UHF on broader stakeholder convenings. We will continue to do that through this process. And we are also doing a little bit more work with the local districts who are very strained and stretched and are doing a wonderful job based on the preliminary data, but we want to offer them some more assistance as well. We've had a robust marketing and advertising strategy for the last year and a half because we had never known when the PHE was going to end. We wanted people to be aware it was coming, and we had focused mostly on print and out-of-home advertising. We want to modify this strategy based on the data-driven decisions, and we will be doing more in the digital space, specifically because we are seeing that younger New Yorkers are not aware of some of the changes that are coming, and we don't want them to lose coverage, try to access services, and not be eligible. So we are taking a digital advertising strategy. These are some of the samples. They'll be in 27 plus different languages, and we want to target those outreach efforts through social media and other media outlets so that we're really reaching people in the mediums in which they're the most accessible. So we're going to be doing more on digital. We're already doing a lot on print. You may have seen some of these. We want to work with our partners, make sure they have access to this information, and that some of that will be with our out-of-home ad samples. You've seen these on the subway. We want pamphlets at the pharmacy. We want all of these materials everywhere possible so that there's multiple access points for people to learn about how they can stay covered. Dr. Barbot mentioned the UHF stakeholder convening. There are a lot of resources available for members to access assistance to enrollment. We have brochures we're putting in the offices of primary care practices, on the desks of pharmacies, because people usually find out they're not covered when they're seeking care. We want to prevent that from happening, but if it does, quickly connect them back to care. And we have various mechanisms to do that. We are hosting a series of webinars. The stakeholder convening in August is going to be very exciting. We will have the final set of the first cohort and what happened. We'll share the coverage transitions. We are seeing people may not be eligible for Medicaid. They are eligible for the other public health insurance programs. One of the benefits of New York's public health continuum is that we have a much broader scale. It's all integrated in the New York State of Health. So we're helping people transition to the products that they're eligible for, including children whose parents may not be eligible, but children could be eligible because of the higher income eligibility. We don't want them to lose coverage. Moving on to the 1115. We have been working with CMS pretty regularly, at this point almost daily, to finalize our 1115 waiver amendment. We are expecting that the approval will come later on in the fall, and we're working diligently towards that. There are several components of the waiver that are still in negotiations, and we'll go through each of those components. But fundamentally, the core premise of the waiver and our thesis has not changed and remains the same. And what that is the integration of social care with healthcare to support population health and improved health outcomes, focused on health equity and reducing health disparities. How are we going to do that? It's going to be through a range of activities centered around population health and health equity improvement, the establishment of social care networks and the delivery of health-related social needs, and strengthening the workforce, which is core to our success. If we don't have the available workforce, we cannot deliver the services to our members. So workforce has been a major focus of this waiver. We're building on the lessons learned under DSRIP. A lot of the DSRIP PPSs and leads have evolved and have informed a lot of the work and proposals you'll see under the waiver. And we're really trying to make sure and always focus on integration. As we bring in and pay for social care services, we do want those to be integrated with health services centered around primary care, also around behavioral health integration. So this is very important, and you'll see some of that as I go through each component, but there is an underpinning. These are interconnected in various ways, and we're very close to having a final agreement. What's shown on this slide is each waiver element underneath those three major categories I just shared. The three boxes at the top are areas where we have conceptual agreement with CMS. They're further established. We have very solidified our goals, and those components are in a very good place. Those are the social care networks, the health-related social needs, the workforce components, and our primary care delivery system model. What we are still negotiating is the Health Equity Regional Organization, or HEROES, and are stabilizing the safety net and advancing accountability and health equity, which is really targeted around financially distressed hospitals. And what is on hold, I would say, are two components of the waiver that we are not going to have in the final approval, but we are fully committed to pursuing under a different authority, starting with the targeted and reach services for criminal justice. So what is, New York back in 2018 was the first state to pursue this waiver to provide 30-day in-reach services to individuals who are preparing to leave incarceration. Recently, in the negotiations with CMS, you may have seen California received approval for a new demonstration. There are a lot of benefits under the California model, and CMS does want that to be a national framework. The other complicating factor is that we're in our waiver demonstration period. So our waiver currently runs through 2027. That means as of today, we have about 3.5, a little bit more, years under this demonstration. Our criminal justice proposal, very ambitious, we would not have been able to implement that statewide in 3.5 years. We do need to do more work. There are system changes that need to be made. We want to do this correctly. And the new demonstration authority that CMS approved for California offers a lot of flexibilities we're interested in, including a 90-day in-reach service requirement. It is very hard to get an individual connected to community supports, enrolled in a health plan in 30 days. So extending that time period is very attractive. In addition, we would have the ability to reinvest savings into the institutions that are serving the criminal justice population, so that we can expand access to services while members are incarcerated, so that they're in a better position when they're leaving to stay in the community. And so we are very committed to doing this. It may not be in the final approval. We are going to pursue it shortly thereafter and try and get more than 5 years, actually, have some 18 months, 12 to 18 months of planning and preparation, and then a full 5 years when we get the waiver renewed. So I want to start with the heroes, because when we submitted our concept paper and our final amendment, everything evolved around the work of the heroes. Health equity regional organizations that were regional planning entities comprised of stakeholders in healthcare and out of healthcare to establish priorities for the region and bring partners together to collaborate and work towards success in developing value-based payment for health equity needs. CMS has, pointed out our time to implement the waiver, and we don't want process to get in the way of implementation. We do strongly believe, and it is a huge priority for us to have that overarching statewide convening and accountability. And so what we're pursuing, and we're very confident we will get, is a statewide hero with sub-regional focuses so that we retain regions identifying their priorities, but we still have statewide oversight to ensure and hold plans, networks, providers, all accountable that we're addressing the health equity needs in each region as identified by the stakeholders. There's also a strong interest in data aggregation. We're collecting so much data under this waiver, and the state is not always the best at putting out data timely and integrating data with outside of the state data sources. So we feel strongly that having that data aggregated by an independent, trusted third party to inform everyone as to what is happening on the ground is critically important so that we can address and continuously improve the design of the service delivery. They will also be working with stakeholders in each region to design and develop new value-based payment opportunities. That will happen in year 1 of the waiver, maybe parts of year 2, and ultimately we want to act on those new designs in years 3 and thereafter, and institute those changes through the value-based payment roadmap and in our managed care contract so that they're permanent fixtures and permanent payment change to address health equities through value-based payment. The last component is program evaluation. It's really to make sure that we are continuously improving and adapting based on what's happening on the ground. Health-related social needs are being implemented by health plans and by providers in a scattered way. We're centralizing that, scaling that, but we want to make sure that we're improving that and that the most vulnerable populations are receiving these services. So one of the core elements, and you could argue heroes is under this element, but is population health and health equity improvement. This is comprised of 2 major areas, starting with primary care. Melinda mentioned it earlier, Dr. Barbot said it, the research all says it, a strong foundation of a healthcare system starts and ends with primary care. And if we don't have a strong primary care system, we will never achieve improved population health. And that's really what we focused on in some of the changes that we've made in the waiver with CMS. It's going to build on what we know works and the infrastructure we created under DSRIP, which is PCMH. DSRIP was incredibly successful in getting primary care practices PCMH certified. We look at the data continuously. Health outcomes are better at PCMH practices. We have a strong infrastructure. We know we can make payments quickly. So we are going to make a statewide investment in the PCMH program with a particular focus on vulnerable populations and children and other high-risk adults. Ultimately, what we want to do and have intended to do, which the waiver will facilitate, is moving the PCMH program from what it is today, which is an enhanced care management payment, to a true advanced value-based payment model. That will not happen in the 3 years of the waiver, but it is our goal to do that in a 5-year period, and the waiver will be critically important to that. Relatedly, and one of the reasons we've made a very strong focus on primary care is that New York has fallen behind in primary care. It's not just Medicaid, all payers. And the Milbank Institute puts out a primary care report, scorecard, I should say. And in 2020, New York, all payers was about 8% of total healthcare spending on primary care. The national average is around 12%. I'm not proud to say Medicaid is probably lower than 8% in 2020. So we really do believe we have to make a strong investment in primary care, and Medicaid can't do it alone, which is why we're going to have a focus on multi-payer models and alignment, including with what you may have heard recently from the Center for Medicare and Medicaid Innovation with their new payment model for primary care called Making Care Primary. Now, Making Care Primary is very important in that it is not centered around the PCMH program, but it is centered around a lot of the foundational elements of the PCMH program, and it's structured in a way that is very similar with a care management payment, and they are trying to move towards quality and ultimately bonus payments. We want to complement the federal model, align on quality measures, and reduce administrative burden for practices and practitioners so that they can focus on delivering care and high quality care. We're also going to encourage and put in place some health equity quality measures in connection to the social care networks, which we'll talk about. But we really believe in the multi-payer alignment, and it builds on the groundwork that New York State had done under the state innovation model, where we had actually taken a regional focus to identify value-based payment models for primary care, and we want to reinstitute that work. How are we going to make the investment in PCMH? This will be a statewide investment, and we're going to start in years 1 and 2 with further increasing. We have a $6 PMPM in place. We're going to increase that PMPM. We're going to increase it even further for children served at the PCMH practices, given the focus and some of our recent outcomes on children. And we are going to facilitate and support movement towards a permanent value-based payment model for the PCMH program. The first 2 years will be similar to how the program is structured today with an enhanced payment. The third year of the waiver, which would be 26, 27, we would have payments based on a bonus structure. So moving from P for R to pay for performance type measures. And we'll do a lot of stakeholder engagement to identify that and streamline the current measure set that we currently have for PCMH to align with the measure set in Making Care Primary. The second component of our population health and health equity improvement is still under discussion with CMS, but it relates around supporting distressed hospitals. And why do we need to support our financially distressed hospitals? Is because they are serving some of the communities in the state with the most health disparities and poor health outcomes. They are essential Medicaid providers, and we need them to focus and improve quality measurement and stabilize, because the healthcare system, especially the hospitals, are struggling right now as we recover from COVID volume. We want there to be accountability in these funding. The state contributes a significant amount of funding to distressed providers, so much so that we have hit every payment limit that exists for hospitals, and we can no longer exceed those limits. CMS understands that, wants to be helpful to address health equity, so we're identifying an incentive-based program that would support targeted financially distressed hospitals to transform their activity, first stabilize, and then over the 3-year period, take transformative activities and develop new capabilities and begin better reporting on health equity. So this will have a health equity quality improvement program surrounding it. We will work with facilities to identify measures, both clinical and non-clinical, that are based on the needs and outcomes of the region. And we are expecting that quality improves and that we can report out on a stratified basis how these investments are resulting in improvements in health equity. So we are close, but we are not all the way there yet. We do expect this will be a final component of the waiver. Now to the social care networks. Very, very exciting. The team has been working very diligently on this. We've given a lot of thought to the establishment of social care networks. These were known as social determinant of health networks in the application. Don't ask me why the name changed. CMS is particular about these things. I like social care networks better anyway. But what will the social care networks be? They are going to be comprised of community-based organizations, healthcare providers, and other community advocacy organizations. And they are really the central focal point for the delivery and integration of health-related social needs. We are planning to competitively select them. We definitely have 9 regions, so there will at least be 9. There could be more, depending on how New York City plays out. We really do feel and want these entities to be permanently sustainable in the healthcare system, and we are expecting by the end of this process that they will be sustainable and be contracting with health plans and paying CBOs for the delivery of social care services. A lot of this work, we know a lot of this work is happening in parts of the state, and we've been paying attention and prioritizing the model design so as not to interrupt, but to augment what is happening or scale what is happening on a regional basis. We need the network to be accountable for the health equity needs of a region. That is what their fundamental goal will be. And I'll talk a little bit about what the services are going to be eligible for reimbursement. It's been tedious fighting with CMS, but I think where we are landing is more comprehensive than what you've seen in the other 1115 approvals. And I'll go into that, and I want everyone to know also that we've been participating in the Medicaid Innovation Collaborative, which brings together public payers and public entities with private sector innovation, and we've taken a lot of our lessons learned there and incorporated into the design. So what are we covering? These are the categories of health-related social needs that we are going to be able to reimburse under the waiver. It all starts with the standardized health-related social needs screening. Every member will be screened for social risk factors and additional demographic data. Data is the most important aspect of this work. And while we know that there's screenings going on currently and everyone is doing screenings, there's no standardization, which makes it impossible to reliably compare and analyze that data. So we want to leverage the CMS Accountable Health Communities screening tool. We want to add some demographic related information, and there will be a core set of required screening questions that every Medicaid member will be screened for. We will allow for flexibility to the extent people want to add or capture additional information, but there will be a core set of requirements, because if we cannot compare and analyze the information, we'll never be able to address the underlying health disparities in each region. We're going to pay for the screenings. We are also getting transitional housing supportive services included in this waiver. Very, very important. Things related to navigation, transitional services, first last month, security, housing supports, home remediation, a lot of big investments in transitional housing supportive services. We do want to focus these services on individuals leaving institution or who may be in an institution but could live safely in the community. That is built off the MRT supportive housing investment and initiative from several years ago. We know there's a return on investment. It's the right thing to do. We want to support that work. And the state's made a down payment on supportive housing in this past year's budget with $30 million to create new units, scatter site units. Also, medical respite with collaboration with UHF. After a long drawn-out process, we do have our formal medical respite regs approved, and that will be a critical component to these services as well. Then going into nutrition, nutrition is something we cover and we know health plans are covering today. So these aren't necessarily new services, but the new element is the integration with the other health-related social needs services and a central lead entity coordinating all of somebody's health-related social needs on behalf of our members. So these will include nutritional and housing counseling, home-delivered meals, medically tailored meals, pantry stocking, and food and vegetable prescriptions. These will be needed in various parts of the state at various volume, and so we'll be monitoring that to ensure that the investments in nutrition are going towards where they need to be going. Very exciting is the transportation. Medicaid does cover transportation, but it's transportation for a medical appointment. And it doesn't help somebody in Queens if you're referring them for a health-related social needs service in Staten Island or in Westchester if they can't get there. So we want to pay for non-medical transportation and care coordination to help facilitate access where there may not be access. Far Rockaway is one area that's relatively isolated. There will be the need to connect people to services, maybe not in the place that they live, but we want to pay for the transportation to get there, which is very exciting, and we fought hard to get. And underpinning all of this is the case management, the outreach, the referral, the boots on the ground, connection to existing infrastructure, connection to new providers, connection to healthcare services, and someone to be responsible for reaching some of the harder to reach members. This is a critical component of the health-related social needs services that will be reimbursed. Community-based organizations do this better than anybody. We have existing expertise in many of these communities, and we want to build on those investments and reimburse for case management. So how will screening and referral work? As I mentioned, we don't want to disrupt some screening efforts that are in place today. Some healthcare providers have screening built into their electronic health records. Managed care organizations are doing screenings themselves, but not everybody is being screened. Everybody will be screened, but so as not to duplicate efforts, we will not necessarily dictate who specifically is doing the screening. We know that we will need our strong community-based organizations to fill gaps, and the social care network will work with health plans to identify where those gaps are and ensure that individuals are being screened. Screenings will flow through the social care networks. Even the ones the health plans and the providers do will all flow through the data and IT platform of the social care network, which will be interoperable and connected to the Shonny, the State Health Information Network, and the qualified entities, so that we have statewide aggregation, access for providers to look into the Shonny to see when the last time someone was screened, so we're not duplicating screenings, and a consistent feedback loop to connect the referral management referral network to evaluate if someone identified as having social care factors and they were referred for services, did they get them? Did they not get them? Why didn't they get them? And if they got them, did they work or did they improve someone's patient satisfaction or well-being? So we want that continuous feedback loop, and we are very fortunate to have an IT backbone like the Shonny that will allow statewide aggregation of the data and access for providers to see the data. When someone gets screened, they may not need health-related social needs. Not every Medicaid member will need health-related social needs. Depending on the screening, there's going to be 2 tracks. This will all be managed by the social care network. If they don't need access to health-related social needs, they will get connected to existing state and local infrastructure for their health needs. Those that identify as having factors will be referred to their community-based network in the social care network and access those enhanced services. We are targeting, we haven't landed on the final populations that would be technically eligible for these enhanced services, but it is going to have a very strong focus on vulnerable populations, including those who are leaving the criminal injustice, are being discharged from incarceration, children under 21, pregnant women and their children, those who have SUD or OUD as a single qualifying condition. So we are targeting very vulnerable populations where we know and the evidence suggests that access to these services are going to improve outcomes and reduce total cost of care. Funds flow, very, very important, because the reason funds flow is very important is not only so that we can pay CBOs for delivery of these services, but also for our long-term goal in making payment reform in how we pay health plans. At the end of this process, our goal is to be able to risk adjust premiums based on social care factors so that we are compensating health plans who are delivering services to high acuity members appropriately. And that sounds a lot easier than it is, but it all is going to start earlier on with some basic funds flow, and this is more of what it will look like in year 1. So the state would be paying through a managed care organization under what we call a directed payment, which dictates the terms of who and what the MCO can pay for. And in this case, the directed payment would be limited to the social care networks who will be Medicaid providers. The MCOs will then pay the social care networks based on submission of social care claims or encounters, and those encounters are not necessarily going to be tied to the payment. They're really intended for us to track and monitor and evaluate and ultimately embed it in the premium at a later point. But it's going to, the social care network is not going to be paying the CBO on a at-risk basis. CBOs will not be taking risk under this construct. They will be paid on a fee-for-service basis. The social care network, ultimately, our goal is that they do manage some risk. They share risk with the health plan for the social components of the premium. But the CBOs are not going to be reimbursed that way. We want to make this as easy for the CBOs as possible, focusing on core competency. And we intend to do that through the social care data and IT platforms that we will expect the networks to have. Those will be interoperable with one another and with the Shonny and the Medicaid data warehouse so that this data is consistently evaluated and integrated into our other Medicaid and other public health data. So we're very excited about this. The first year, obviously, would be very, very heavily focused on screening. Because the screening is what dictates the eligibility for the service. But in the latter years of the waiver, we intend to do more value-based payment between plans and social care networks to innovate and test out new delivery care models. Last, but definitely not least, is around the workforce. This is the third pillar of the 1115 and an area where we have great partnership with the federal government in recognition of the widespread need for clinical and non-clinical professions. We are taking a multi-pronged approach here. Some of this is related, you may have seen the loan forgiveness in the Massachusetts approval. We want to incentivize young professionals, those higher education professionals, to serving the Medicaid program in high demand areas or high demand professions where we have a dearth of availability and access. Areas like dental care, psychiatry, pediatric clinical nurses. These are very clear needs. We don't have access in all parts of the state, and there are barriers to getting young individuals with reams of medical or educational loans and debt to wanting to serve in some of our Medicaid communities. So we want to forgive some of those loans as a condition of them serving the Medicaid program and being employed by a Medicaid provider. And we're going to do that for targeted clinical specialists where we know we don't have enough professionals in the program. Supporting that, though, is a very, very large career pathways training program. And this really is an important health equity focus. Many of our current healthcare workers don't have the ability to move up the career ladder because of health-related social needs and social care factors. When you're deciding between whether you get paid or you go get trained, you have to get paid to put food on the table for your family or for your children. And that is a barrier to mobility and economic advancement. So we are developing a range of career training programs which will be funded through and managed by high-performing workforce investment organizations that were also established under DSRIP to allow for those training programs in various clinical and non-clinical professions. Nursing titles, mental health practitioners and peer support specialists, and then also community-based workers like community health workers are all going to be embedded in these career pathways. It's a very big responsibility for the WEO. We are going to have a lot of responsibilities imposed on them. We want to know pre and post training wage information. We want to know how many people went through training, completed training, what type of training. We have limited the trainings to under 3 years so we can actually evaluate, because our goal under this proposal is to support 20,000 either new workers that are either new to the profession or being retrained at an existing healthcare provider. So we're super excited about this and very, very eager to get this underway given the needs in the delivery system, and it will be a core focus of the waiver. What have we done to set up for this? The last 2 years under the governor's leadership, we have made massive, massive investments in the Medicaid program, all centered around preventative and population health. This past year, we increased our spending by almost 10%. I mean, this is really unprecedented based on my history with the program, where we averaged around 3% year over year, which made it very hard for us to make sizable investments in preventative care. The program has grown tremendously. We've expanded access to services and benefits that I'll talk about, but I did want to highlight at the onset the major focus of this last year's budget, which was access to behavioral health and the $1 billion investment that was made to support behavioral health. We, the Medicaid program, supported some of those investments in collaboration with the Office of Mental Health, and we're establishing at least 12 CPEP programs, more ACT teams, at least 40, tripling the number of CCBHCs, and expanding Health Home Plus, which is Health Home for seriously mentally ill and higher needs individuals, and then a very, very strong focus on school-based mental health services. 20% increases in those rates, very much focusing on access to behavioral health in school that will be connected to the social care networks and connected to the work the health plans are doing. And then we also had a 1.5% other state agency cost of living adjustment. I think this is a very exciting time. It's not often I recall there being this significant of an investment in behavioral health and specifically access to behavioral health. And we're very proud to be working with OMH on implementing some of these investments. Where we have focused and was, outlined in the governor's state of the state this past year, all of which was supported unanimously by the legislature, is everything we're doing to support primary care and prevention. I look at this as a down payment on the 1115. We're investing in supportive housing, $30 million. We're benchmarking our primary care reimbursement rates to 80% of Medicare. We're expanding access and creating a statewide doula program with some of the highest reimbursement per pregnancy in the country. We're increasing vaccine administration rates for children, and we're updating and improving our integrated licensure standards, really to continue the focus on integration and ensure that people get all of the care they need when they come into a healthcare office. Last but not least, I did want to highlight the community health worker investment that is being made. We've spent a lot of time working on this, and we're very excited about this. This is going to take effect in January and will specifically be targeted towards higher needs populations. And we're building this out right now, really in anticipation of the waiver, because we expect community health workers to be at the core focus of these community-based organizations, doing screenings, connecting people to supports, really core to integration of these health-related social needs services into the healthcare system. And we're very, very excited about this and are putting deep thought into this. Also, we're covering adverse childhood experiences screening. This is something the Commissioner of Health, Dr. McDonald, is very passionate about, and we do intend to do outreach and education for pediatricians to be able to institute these screenings and act on these screenings. We have to get to some of these issues earlier in life to prevent downstream effects, and that is what every single one of these investments is intended to do. And I'm very, very excited about how these investments are going to complement and improve our chances of success in sustaining waiver investments. I look forward to your questions, and thank you for your time today.
Good morning, everyone. Hi, thank you, Amir, for your keynote presentation. I am Emily Arson. I'm a Senior Health Policy Analyst in the Medicaid Institute at UHF. Thank you all for being here. We are now going to open the floor to questions. So please feel free to line up if you have questions for Amir. And I will start with one of our online questions just to get us started. Yes, we have... How will the 1115 waiver complement the new CMS Making Care Primary demonstration for New York State more broadly?
So the Making Care Primary model that CMS just announced, it is a Medicare model. It does have minimum Medicare requirements to be eligible, and it's voluntary. So we're not sure that every practice is going to choose to participate in Making Care Primary. We think it's going to be more appropriate in upstate New York, given the Medicare minimum participation. But how it will complement is that both Medicare and Medicaid will be paying an enhanced payment for the same set of services that will support integration between the two programs, and then we're going to align on the quality measures. PCMH is pretty rigorous in its quality evaluation and all of the measures that a practice needs to meet. And what Making Care Primary provides is a very core set of measures that do revolve around health equity, which is aligned very closely with our 1115, that we would like to align the PCMH quality measures with. So they are complementary in that way and will really support advanced primary care and practice transformation, because Medicaid can't do it alone. And that was the point of the slide that showed that we're at 8.2% total primary care spend. That's not just Medicaid, that's all payers. So we're a lot stronger with the support of Medicare, and there is alignment in supporting streamlined practice transformation and reduce burden on practitioners.
Hello.
Hey, Laura.
Hi, Laura Castle, Medicaid Matters, New York. At least 2 states have now pursued continuous coverage for the youngest children. And I wonder if you could talk about what New York might be pursuing to get continuous coverage for birth to age 6.
Yes, thank you for the question, Laura. And we're very, as you can tell, focused on access to services and quality improvement for children served by the program. I think there is some mutual interest in thinking about whether that would work in New York or how we could do that in New York. I think the challenge we have is that we did not include that type of an proposal in our application, so it's not something necessarily that can be done as part of the waiver approval at the moment. It is something we're exploring, we're interested in. We are focused on coverage gains for children through the unwind. As you've seen and heard, children are losing coverage in other states quite extensively, and we are very concerned about that. So it's something that we're discussing and exploring. Not sure if it would be included in this approval, but it's something we may pursue shortly thereafter.
Great, thank you.
Hi, Harvey Rosenthal, New York Association of Psychiatric Rehab Services. Peer support is very important to our world and the people we support, people with mental health addiction and trauma. You mentioned something about peer support specialists, enhanced training through the WIOs, if I have that right. Could you say more about that?
Yes. Oh, you want me to say more about that? Okay.
Say more about it.
So yes, I mean, this is, as part of the Career Pathways training program, we do want to have a very strong focus on broader behavioral and mental health practitioners, including peer support specialists. What we want to make sure is that these WIOs, which we do have in place today, they were established with a particular focus on long-term care, at least at inception. They've evolved. And so as part of a streamlined application process, we want to select a smaller number of WIOs that have demonstrated capacity in providing these types of trainings and partnerships with education institutions and healthcare employers so that we can help people get into the workforce as well as retrain our incumbent workforce. And that will be a category we focus on as part of those programs. Don't have specific numbers on the number, but it is going to be a focus, and as are many other behavioral health and mental health practitioners.
Thank you.
We have another question from online about the unwind. Can subsequent iterations of the monthly dashboard be delineated by Medicaid program type within, so like, by MLTC, MAP, HARP, SNP, etc.?
We will think about that. It's a little bit harder to do given some of the reporting, the inflows of the various reporting streams, but I think that's something we can certainly explore. We're very committed to providing as much data as possible. As you can tell, the dashboard report is we are very open to being transparent about what's going on. We are doing that because we want people's help to target outreach efforts to reach those that maybe the numbers may be suggesting are not renewing more continuously. But we will think about that and try and institute that into the report. We've put a lot of time into the report, so I don't want the team to kill me. But yes.
Hi, Amir. Zach Hennessy, Public Health Solutions. We operate a whole UNYC network of community-based organizations here in New York City. First, I just want to say this is a really critical and missing piece of the public health infrastructure. I really hope that it can be developed in a manner that allows it sufficient flexibility to be used as a resource for all other sorts of government purposes. There's a really critical need to better connect the social safety net. One of the concerns, I noticed on your diagram, you kind of have the services that will be provided as part of the scope of services, and you have a clear pathway for members who are eligible for those services to access them. But is there any sense of what will the increase of demand be on other parts of the social safety net services for those members who are not eligible for what's provided on the fee schedule? And are there opportunities to work with the other agencies to help them prepare for potential increases in demand in those areas?
Can you give me an example of what type of other services you're referring to, Zach?
Sure. So the housing set of services is somewhat limited. People may or may not be eligible for all of those resources.
Okay.
Food and nutrition.
Yes, now I better understand your question. It's a good one. We are going, for those that I don't want to say are ineligible, but who may not be identified for accessing some of those services. What the social care network will be responsible to do, and specifically on the case management, is connecting those individuals to the existing state and local infrastructure for which they could be receiving those services. And that includes other state agencies, other localities, city health departments, local health departments. So there will be that connection. But I would say that I think we are trying to be as inclusive as possible in terms of who is eligible. And it's not as though we are going to be as limiting. Housing is hard just given the availability of supportive housing. So we really do need to target that towards the most vulnerable populations. And obviously we want to get people out of institutions that can live safely in the community. But for those other services, absolutely, that will be the responsibility of the network. And we will document and monitor that they are doing that appropriately.
Thank you.
So I think we'll take one more question, but before we do that, we'll break at 11. I just want to remind folks, please scan the QR code to fill out a survey of this keynote. As Dr. Barbot said, it's really helpful for us in planning future conferences. And for those of you on Zoom, you should have a little pop-up box, which is a very easy click for that feedback. And we'll...
Sure, thank you. I'm Jason Lippman, currently an independent consultant. Thank you for your information and comments. My question is, how do you see the 1115 waiver being used to meet the behavioral health goals that you touched upon, given behavioral health's impact on primary care and emergency services?
It's a great question, and there was a slide I wanted to share that it's just not there yet, but it relates to the eligibility for the HRSN services, and effectively there's going to be a focus on connection and integration to behavioral health. All of the work we're doing with the primary care delivery system model, the investments in the safety net and the financially distressed hospitals will have requirements and quality improvement activities around integration of primary and behavioral health. It is a core focus for CMS. It's something we fundamentally believe in, as evidenced by some of the investments the governor has made in this past budget and what we're doing on integrated licensure standards and reimbursement of mental health services. So it will be an underpinning and an expectation and embedded in each component of the waiver, from workforce, population health, to the primary care delivery system model.
And with that, can we have another round of applause for Director Amir? Thank you so much for your time and your dedication. We are now going to take a 15-minute break to set up for our morning panel. Strategies for providing substance use disorder treatment and care to Medicaid members. We'll be back here at 11:15. So thank you all. Thank you.
I'm Giovanna Braganza. I'm a research analyst at the United Hospital Fund Medicaid Institute. I have the pleasure of introducing our first panel today, which will cover strategies for providing substance use care disorder treatment and care for Medicaid members. The session will be moderated by Ken Shatzkes, who is the program director at FAAP, the Foundation for Opioid Response Efforts. Ken has spent his career performing biomedical research in academic, government, and nonprofit settings on opioid crisis-related initiatives. Ken leads FAAP's programmatic activities and helps to identify new funding opportunities for patient-centered, evidence-based solutions to address the nation's opioid crisis. Our esteemed panelists bring a wealth of knowledge and experience in providing substance use disorder care to patients across New York State. Shonny Capodilupo is a licensed clinical social worker who leads Open Doors behavioral health programs and is responsible for advancing the integrated care model for behavioral and physical health for families. David Collymore is a pediatrician and serves as the chief medical officer of the Acacia network. Daniel Schatz is an internist and addiction medicine specialist who serves as the director of program and policy at the New York City Health and Hospitals Office of Behavioral Health. Full bios for all of our panelists will be posted on the UHF website, and I will now turn it over to Ken to dive into this important discussion.
Great, is this on? Can everyone hear me? Excellent. All right, so thank you so much for inviting me here today to moderate this important conversation. So first off, just quickly, I'm Ken Shatzkes, and I'm happy to be here on behalf of the Foundation for Opioid Response Efforts. For those that don't know us, we're a national grant-making foundation that was started in 2018, located right here in New York City. In the 5 years that we've in existence, we're celebrating our 5-year anniversary at the end of the year. We've given out over 100 grants worth about $40 million across the country around opioid crisis initiatives. So I guess that's why they invited me to talk a little bit about and moderate this panel here. So, I just want to start off first by allowing all of the panelists to describe the work that they do, their organizations, as well as the type of SUD services that they provide. So, David, why don't you start?
Great. Good morning. First, it's an honor and a privilege to be in front of you, to be part of this discussion. Glad to hear you've awarded $40 million in grants. I don't think we were one of those awardees, so we definitely need to connect.
We can talk after.
Post this. But my name is David Collymore. I have the pleasure to serve as the Chief Medical Officer of the Acacia network. So we're a multifaceted organization that does a host of things throughout New York State and beyond. We have federally qualified health centers throughout the Bronx. We have a health center in Queens. We have 2 Article 31 mental health centers. We have a large behavioral health network throughout the state, including 6 outpatient methadone treatment programs, 2 in the Bronx, 1 in Brooklyn, 1 in Albany, 1 in Buffalo, 1 in Dunkirk, New York. We have 8 residential treatment programs throughout New York City. We are one of the largest homeless housing providers for the city of New York. We have a couple thousand units of affordable housing, including 100 units of affordable senior housing in Puerto Rico. And we have workforce development in multiple states throughout the United States. So we do a lot. We keep busy. Whatever our communities need, we want to service those needs. So it's a pleasure to be here to discuss the work that we do, to talk about how we can collaborate with all of the organizations that are represented here. So I'm looking forward to the next hour or so of discussion.
Great, thank you. Shonny, do you want to introduce yourself?
Sure. I'm Shonny Capodilupo. I'm the Senior Director of Behavioral Health at Open Door Family Medical Centers. Open Door is a federally qualified health center with health center sites across Westchester and Putnam County, as well as a school-based health center in Weebatuck and a dental program in Saugerties, New York. So we have a fully integrated program embedding behavioral health directly into primary care. and I'll talk a little bit more about that later, but it is really important to us that substance use disorder care be a primarily addressed condition alongside other health conditions. And so we definitely emphasize the whole person and whole person care at Open Door. Thrilled to be a part of this talk today. Thank you.
Thank you. And Daniel.
Yes, good morning. Thank you for having me. My name is Dan Schatz. I'm an addiction medicine provider. My title is Medical Director for Substance Use Disorder Services at Health and Hospitals. Health and Hospitals is the public hospital system in New York City. We have 11 different acute care facilities and maybe about 70 community FQHCs. Our addiction services are vast, including our Oasis regulated methadone clinics, our chemical dependency programs. We have a lot of outpatient care in the addiction world, both in psychiatry and ambulatory care and in the community. But then we also have a lot of show vans that go into the community, in the emergency department, and in inpatient care as well. So we're really all over the place. We like to try and treat patients whenever they approach, and with no wrong door, kind of low threshold care, and engage them right away. So thank you for having me. Look forward to the discussion.
Thank you, and fantastic. I like the start of this already with the no wrong door. I think that's going to be quite a theme in this conversation today. But I want to frame the situation right now before we jump into solutions. Over 108,000 people are dying of drug overdoses in the country in the past 12 months. Primarily due to synthetic opioids, such as fentanyl. We have 2.7 million people with opioid use disorder. The majority of those individuals are covered by Medicaid, or the large share of those are covered by Medicaid. Yet we still know that only 1 in 10, and that's probably being generous on that, 1 in 10 access evidence-based treatment for substance use disorder. So I want to start really by talking about why is that the case? What are the barriers that are preventing people, and specifically our most vulnerable populations, from being able to access this life-saving treatment? So why don't we start with David?
Right, I think the barriers are numerous. I think there's still quite a bit of stigma associated with accessing care. There are folks that are in hiding, hoping for a better day. So I think we really need to be intentional about going out there and getting to those individuals. We've been doing quite a bit of street outreach. We need to do a lot more community partnerships. We've been talking with some of our Queens-based local community board electeds about doing a faith-based initiative where we're going into churches and educating individuals. The substance use disorder epidemic has touched us all. I don't know if at this point there's anyone in our country that does not know of someone or have someone that is directly connected to them that has battled with substance use disorder. So I think we're at a point now where we need to admit to ourselves that this is a problem of all. It's not the 70s or 80s of the crack epidemic where we thought it was them that had an issue. It's every community, it's every demographic, every socioeconomic level, and it's really going to take a community-wide recognition that this is a medical issue. So there's a tremendous amount of education that has to go into educating not only the medical community, but the community at large in understanding the scope of what we're dealing with. So I say education. I love the no wrong door statement. I think I'm going to use that quite a bit now. Thanks, Dan. And just having no barriers to care. We have to meet folks where they are at the point of their need and be available when they are ready to make a decision to change their lives.
Fantastic. And Shonny, a lot of the work that you do is in rural communities. And I'm curious if you can talk a little bit about the barriers that might be unique to Medicaid members that are located in rural communities.
Right, and by rural, that is relative, given the New York City perspective. But certainly, transportation can be quite a barrier, and services are spread out in a larger geographic area. Open Door really sets their, really takes that into account and really tries to locate their health centers in a location that is densely populated and offers the ability to walk to services as much as possible, but also, services and transportation become a concern. Public transportation is not widely available as it is, and if it is, it consumes much of your day to make that journey. Lots of transfers and lots of waiting. So the ability for us to have a robust service delivery under the umbrella of the health center and in a location that is accessible and as Daniel said, really creates that no wrong door and that barrier-free access to care is super important. And certainly for Open Door having a large population that is undocumented and uninsured, having access to those services within the umbrella of care, because the moment you refer out, you're increasing the likelihood that those services are not going to be able to be accessed, and those that care delivery is going to get interrupted. So we try to have as much under the one umbrella as we can.
Fantastic. And one of the solutions, that was put forth around the transportation barrier was actually brought about out of necessity during COVID, which was an allowance of telehealth to be able to treat this population. And Dan, I don't know if you want to speak a little bit about how you've been able to utilize telehealth during this time and what the patient experience has been. Yeah.
Well, first, I just want to just re-up what David said about stigma and being a huge barrier there. Being in the healthcare center, I'm just so thankful for all the community organizations that are able to truly be harm reduction and be able to meet the patient's needs in a certain way that a more stuffy healthcare system can't necessarily do. And that starts with acceptance of the patients and where they're at, and that's a huge issue. So even a patient coming through the doors of the hospital or our community facility is a big step forward where they've been previously stigmatized or traumatized. And then the link to this is saying that they have to go through all this. They have to go through half a day is what I assume is the basic to see a doctor, half a day to see them, let alone the transportation, all that, to get the prescription that might not even go through, versus, I don't know if any of you have read, I'm sure many of you have read Dreamland, where it talked about the Halexo boys, and they were kind of like the Amazon of drug delivery. It's just so much harder to get a controlled substance from the medical system than for them to just get heroin, call their dealer, and they'll be there in a second. So really anything we can do to make it easier to access whenever they need it. So telehealth, to your question here, there's many barriers, and we'll get to many of those, but just because you gave me telehealth, that allowed them to get care that day, right away, no matter where they are. In New York City, that was incredible. I know phones are an issue, but we have the New York City Link phones on the side of the street. Patients were calling us from those phones and telling us we'd get a full history, get them the medication, and they had a number that they can call us and contact the right person who could facilitate all of the care. So it's just getting that same day care is so critical, because if you don't get it, you're in withdrawal, you feel sick, you're nervous, you're scared about going into worse withdrawal, and you know what the answer is, because there's a dealer who you have their number and they'll be right there. So we need to get closer to easy access as this other option that they have. And telehealth was one way that we were able to do that.
And I know that we as a country, we've tried our best to remove some of these barriers, such as the X waiver, and to open up the number of providers that could possibly prescribe buprenorphine. Data from our projects have actually found that since the X waiver has been removed in January, there hasn't really been an increase in the number of buprenorphine prescriptions or providers that are prescribing. So that idea of stigma, Dan, as you mentioned, I think is pervasive, and it's going to take changing hearts and minds of providers to want to prescribe this medication. So I was wondering if you can just speak a little bit more about that from the standpoint of primary care, from getting more providers on board and destigmatizing this disease to treat these patients.
Yeah, great. I actually have a fortunate position to be able to see all the providers in all these different treatment areas and see what the prescribing patterns are. And we certainly haven't seen an uptick. I don't think we would have predicted to see that uptick right away, just because of, originally came out and said you need 8 hours of training to be able to do this. And so that like made it seem like it's a big deal. And then you go in and you're like, nope, you can't die on this medication. Yes, the ceiling effect is really incredible. The only thing you need to do is watch out for induced withdrawal. So I just think it's going to take a little bit of time for clinical staff to feel up to being able to do this. That's within their ability and skill set to do it. When I look at younger providers coming through and recently trained, they're ready to go, to be honest. So I'm very hopeful that the removal of the X waiver is a huge barrier, but it just takes a couple of years for that to be integrated, because it's not like the ED provider needs to continue their treatment, but I do need them to feel comfortable to be able to give this medication, start them in that right direction, or for a primary care to cover somebody. It doesn't mean you have to manage that long term because there's a lot of psychosocial issues there. But someone mentioned education, and education is going to be critical to that. So yeah.
If I could just jump in here and add, I think education really is the key. Prior to the X waiver, and thank God it was removed. I don't know why it was ever implemented. I remember probably about a decade ago, I was at a conference and made a statement that, I can prescribe an unlimited amount of oxycodone, but I'm limited in who I can prescribe buprenorphine for. And it took us over a decade to realize that was wrong. But I think education really is key because, most of us that trained, more than a decade ago, I think I had maybe about 5 minutes in medical school talking about substance use disorder. And that was really just talking about the use of naloxone to reverse an overdose in an ER setting. And that was about it. So, I believe things have gotten better, but it's still not where it needs to be in terms of medical education. Our providers are still hungry for education when they come out of training. So we are very intentional in our organization about training providers on the job, partnering them with experienced providers so that they become comfortable in prescribing. Removing the X waiver alone is not going to change the educational deficit. That really needs to be intentional and happen over time, and training every level of a medical provider. So that folks are comfortable, they understand the physiology, they understand the pharmacology, they understand the fact that this is a medical illness and it's not a choice or a decision that folks have made. But I think education really is the key in getting additional providers to prescribe medication-assisted treatment.
Well, let's stay on this theme of providers and workforce. We heard today about initiatives around increasing the behavioral health workforce, and there is a shortage right now, not only in New York State, but across the entire country. So I want to follow up on that and ask you what kind of strategies are needed in order to build up the behavioral workforce that's willing to help this population?
Yeah, I think in addition to education, I think equipping folks and getting folks interested in providing addiction medicine services early is key. And early, could be as early as high school, college. We all talk about medicine with our children and say this is a wonderful career for you to go into very early on. We talk about pediatrics, we talk about surgery, we talk about internal medicine. Rarely do we talk about addiction medicine. So I think we need to start that conversation earlier. The kids are affected by it, so it's not a new subject for them to engage in. So I think preparing folks earlier is key. Workforce is probably my biggest headache and pain point. Finding staff at all levels, providers in particular, but also social workers and peers and workforce is a tremendous challenge. So we've got to a point where we're very, I would say, flexible in terms of, we're hiring folks that have part-time availability. The other day I met with somebody, they said they had 1 day a week availability. They're an addiction medicine board certified specialist. I said, you're hired. Years ago, that would not have been the case. I would have said, no, we need somebody that's full-time. We'll get back to you if we have a need. But I think as much access as we can provide in this day and age, we need to be flexible. There's a lot of flexibility that was put into play with telehealth during the pandemic. We need to fully understand that remote work is a phenomenon of the present and the future. But I think, flexibility, education, training, all of those things need to be bolstered to enhance our workforce. And of course, reimbursement. I always say you get what you pay for, right? If plastic surgeons are making, $1 million a year, and then you want an addiction medicine specialist to struggle with a fraction of that, you're not going to get folks going into that field. Medical education is very expensive these days. I don't know if I would have made the decision to become a doctor today if I was faced with that level of debt. So you have folks going into other careers, you have folks going into other specialties for financial reasons. So I think reimbursement has to change. There needs to be money put behind the care that we want to render.
Fantastic. And I know we're talking quite a bit about medical providers, but there are other providers that we need in the continuum. One of those being pure recovery coaches, health navigators. So Shonny, I don't know if you want to talk a little bit about other roles that we have a dearth of shortages right now that could be incredibly helpful in caring for this population.
Sure. At Open Door, we have a fully bilingual clinical staff because caring for our patients in the language that they are comfortable speaking in, especially when you're, communicating around very deeply emotional and sensitive issues, you really need to be able to speak in that language that you're comfortable in. And so, having a bilingual and bicultural staff is incredibly important. More than 70% of our patients prefer to speak in Spanish. And so, having those supports that wrap around that patient is incredibly important. We have advocates or navigators, as they're often called, that help link the services and supports in the community, because many times the receptionist that's picking up that phone is English speaking, and right there you have a fail in that referral. If I could just jump back to that workforce, if I may, in the training for a behavioral health clinician, historically, substance use was parceled out. If you're engaging in treatment for a person who had both mental health and substance use disorder services, the prevailing thinking was get that substance use under control, and then we'll treat that depression or other mental health condition. Now we know better, and having that co-occurring care happening and that priority. But I don't think that the landscape has shifted enough to ready that behavioral health clinician to be comfortable treating as substance use disorders as an equal priority to that mental health issue, and keeping, after all, they're both in the DSM, and that is our go-to. And so having that team-based approach with that medical provider, I think offers that support both for that medical provider, having that behavioral health clinician as part of that team, but it also helps instill some comfort and confidence in that behavioral health clinician, that they have an expert in this that they can go to, and together that they can work on these issues so that that patient is not having a very significant part of their healthcare ignored.
Great, thank you. And I'm glad we're moving on to integration of all of these different services that are needed to care for this population. And earlier this morning, when they were talking about the social care networks, when I saw that slide go up, I thought right away that this is essentially the same as recovery capital, which is required for those that have substance use disorder. We know that those that have larger amounts of recovery capital, such as access to transportation, housing, employment, they do better in the long term around substance use disorder. So incredibly excited that the 1115 is looking to include that. But Dan, I'd be curious to hear from you a little bit about, what are those other social services that are really needed to have that wraparound care around someone with substance use disorder, aside from the medical treatment itself?
Yeah, I mean, there's great points throughout. I obviously wanted to comment about so many of them. But I do have to say, our Oasis clinics, we can hire for peers, right? And we can bill for what they do. Community health workers or community liaison workers, I like using the CLW more. It's been really interesting since the pandemic happened. We had a huge groundswell of hires that were just calling and doing the tracing. And now we're like moving them over into community healthcare workers or community liaison. And I think that they're fundamental. They're so critical. I think of them as problem solvers. Much of what I do, again, my piece is kind of easy for a lot of the patients. It's come in, great, I diagnose you with opioid use disorder, here's your Suboxone, we'll see you again. Obviously it's a little bit more complicated than that, but not that much. But then all the other barriers come in right after that. And so that CLW can make sure you actually got your prescription, and if not, problem solve for you. They can liaise between myself and the patient. They can liaise about that and the housing. They can liaise with that and just getting you some food or some clothing or whatever it is. And I don't know of a way I'm able to bill for any of the critical work that they do. But I think that that's going to be fundamental to being able to give the care. And it's hard to define because they just problem solve whatever the issue is. You call for a missed appointment. If they're Spanish speaking, talking to their parent who might be in Puerto Rico to be able to identify where they might be able to be found and contact. But even the peers, I can't do that in my outpatient primary care clinics unless we start getting creative about being hired from Oasis and, giving comprehensive care that way. So those are, I would love to see the CLWs be able to allow for us to bill for it. Would be critical. Otherwise, you're spending, however much dollars per hour for me to call patients and navigate stuff that's going to be frustrating, make, me pull my hair out, make me burn out. And I'm not good at it compared to what the other individuals do. So it's retention too. So it builds into it. I love working with them. They're great.
Not to mention peers are those with love. Many of them have lived experience. They've navigated the system before. They know, who to go to. They know it's these little tips and tricks within this really complex system that we've created that really, if you are just entering it, is very hard to navigate. FORA actually commissioned a large national survey, we believe the largest of its kind across 13 different states of certified peer recovery coaches. And when we talk about a workforce issue, this is a workforce that wants to do this work. The idea, all they're asking for, and we asked them, okay, so 2 years from now, do you see, with all of the issues around reimbursement, a lack of career opportunities, do you still see yourself working in this role? And 85% of them said yes still, which signifies to us that this is a group of people that are motivated to do the work because they care about it. The other thing that they will obviously need is financial reimbursement. I think anyone needs to be able to provide the basic needs for themselves. But then we asked them 5 years from now, and still 80% still would say. So we have a workforce that's ready to go. We just have to provide them the opportunity to do so, and they may be the most appropriate people to help bridge the gap between medical providers and social service providers in the community. So I want to get into specific communities now as well. And Shonny, you started on the importance of cultural competency and bilingual services. But David, I know that you have the clinics all over the place in different communities, and I'm just wondering, how do you approach that? How do you build in that competency for each community and really hone in on that community's needs?
Well, I think, in this day and age where we discuss healthcare equity quite a bit, I've always said that your workforce needs to resemble the community that you're serving. So wherever you're located, you need to identify individuals within that community that are trained and skilled and qualified to perform those jobs, but you should be intentional about hiring from the community. At Acacia, we pride ourselves where our leadership is reflective of the communities that we serve. So I think it's very important, in terms of proximity to your locations. Our folks up in Buffalo, even in the midst of a snowstorm, because they live close, they navigate through 4 feet of snow to make it to the centers to provide that care. It also gives them sort of a cultural familiarity with the folks that we're serving. And there's no greater passion or motivation than an individual that can relate to who it is that they're serving. You know, there are nuances to every community, even with the substances that are utilized. There are nuances to that. You know, up in Western New York, we see a larger percentage of folks using methamphetamines, whereas the stimulant of choice in New York City is more cocaine. So you have to understand the nuances of who it is you're serving, ensure that your workforce resembles who they're serving, and be intentional about that.
And Shonny, I'll direct this one to you. Open Door serves a mix of Medicaid members and immigrants. And I'm curious to hear, you know, what is that experience and what are those other services that you build in specifically for that population?
Sure. As I said before, the moment you refer outside our walls, you're increasing the likelihood that those services and supports are not going to be met. So we do our best to have as wide an umbrella as we can of services and supports underneath one umbrella, and have that fully integrated and part of that network of care. And so having that fully integrated behavioral health team with the primary care, and that primary care serving not only across the age spectrum. So we have from pediatrics through women's health and OBGYN and right through internist and elderly care. But we also layer into that nutritional supports, podiatry, optometry, dental, and you know, all manner of specialties, as well as things like having a WIC program that's on site, having insurance enrollment that's on site, because that transportation to get to other locations, it's incredibly important to have those as part of it. We even have a wellness center, a little mini gym that patients who have diabetes can go and take yoga and do Zumba classes and not only become more physically active, but create a network of support with their peers that are participating, because isolation is a huge, and loneliness is a huge piece of this, and that circles right back around into addictions and alcohol use and other unhealthy coping and adaptation. So having like you said, that the clinical staff and supports from the MA straight through to the provider, really mirroring who we're serving and speaking in a language that folks are comfortable in, but also understanding how our patients have to navigate in this world and those social determinants of health issues, and fielding for those as much as possible, and really providing those supports under one umbrella so that we minimize that handoff outside our walls where things have a higher chance to fall apart. And so in that way, and creating that solid team of care, that everybody's on the same page, and that we're working in unison toward the needs that are represented.
I'm glad you mentioned loneliness. In our pre-call, that came up, Dan, around a loneliness crisis. U.S. Surgeon General, declared there's a loneliness and mental health crisis in this country right now, and that's directly overlapping with the substance use disorder crisis, the overdose crisis. So, would you like to speak a little bit about that overlap, and what we have to do?
Absolutely. I think loneliness is, it's now been brought up to my mind as being incredibly important. And Dr. Vivek Murthy, listening to his book right now, actually, together, which I would recommend as well. This is my second book recommendation, I guess. But I think loneliness goes both ways. First of all, a lot of our patients have experienced childhood trauma, which we know creates loneliness. It creates a barrier of connecting to others. It withdraws into yourself. And a lot of times the answer to that might be substance use. Unfortunately, continued substance use pulls you farther and farther away from other people, further making loneliness worse. But then also, as I started working more in this field of loneliness, starting to dig into the evidence and whatnot, I started noticing all my patients are actually lonely. That they say when they're feeling lonely, that's when they use. And sometimes I don't even have to throw that word out. And I started digging into it a little bit further. And, we need to be clear about isolation versus loneliness. Because during the pandemic, we were isolated a little bit, but actually some people didn't feel as lonely because now all the virtual meetings were happening and they were able to connect with loved ones. So there was a benefit in that sense. The easiest way for me at least, to describe the difference between isolation and loneliness is someone who's really famous is not isolated by any means, but they might not have anyone they can feel they can be themselves to. How this plays out for patients is, when I was doing more primary care, it was always the hand on the door. Oh, I have chest pain radiating. And I'm like, okay, I'm going to sit down and we're going to dig into this a little bit more. Now it seems like a hand on the door, and they just keep wanting to bring up something else up to keep the conversation going. And I recognize that what they want is connection. They're using me as a form of connection, which is wonderful and happy to be able to provide. But I have certain hours and there's a certain relationship and there's a division there. And so I used to encourage patients saying, hey, what are your hobbies? What do you like to do? Can you get involved with your local church or your local, group X, Y, or Z? And if they said, yes, I'm doing that, I'd pat myself on the back and say, great job. But now I actually take it one question further. Are you connected with anybody? Can you ask anybody for something when you're in need? And I realized there's actually quite a big division there. And pushing someone to have that vulnerability to open up to somebody is a big step for those who have experienced trauma in particular. So I just think loneliness is perfectly intersected with addiction and trauma. And I think it's for a lot of patients, that's kind of the underlying issue here. And just to wrap this up, someone asked me to connect loneliness to addiction as I was walking back home, and I saw a restaurant with a sign outside that said, are you hungry? We have food. Are you thirsty? We have booze. Are you lonely? We have booze. And it's like, I was like, well, that was pretty spot on right there. And I understand what they're saying. And, okay, I guess it's a laugh, but it's also highlights that it's known. We feel it. And the patients know it too. So thank you for giving me the opportunity to talk about that.
Of course. So before I jump into things other than treatment, because again, I feel like on that call, we said we could have talked here for about 3-4 hours, so we want to focus some things on here. But I want to go back to the 1115 waiver. Just say myself a little disappointed on the justice provision not being potentially not being included here. For those that don't know, California did receive an 1115 amendment around being able to provide use federal Medicaid dollars in jails and prisons 90 days prior to release. This is the first time ever, and our grantees, Legal Action Center, in their words, this is a game changer in the way that we provide care. And Dan, I know H&H, you guys provide services to those that are leaving incarceration. We know that from a study in North Carolina that in those first 4 to 6 weeks, you have over 40 times more likely to have a fatal overdose in that time period during reentry. So Dan, do you want to speak a little bit about that care continuum and what we really need to be able to help people leaving incarceration?
My goodness, the difficulties that these patients face as they're being released, it should be like a joyous moment you're being released, right? And yet everything is thrown in at them at once. Just quickly putting aside all the other Maslow's hierarchy of like, how am I going to do housing? How am I going to talk to people? How am I going to repair these relationships? Putting that aside and just talking about the medication. Medicaid is turned off. It's inactive when they're put in prison or jail. And when they're released, now they see me and I put in the medication and their insurance is off. And it's crazy. It's pretty easy to turn back on, but that is a 24-hour delay. And meanwhile, they have other things they need to follow up on and they're scared about going into withdrawal. Again, luckily at Health and Hospital, we have ways to be able to go around that and provide the care right away. But that's a huge delay. And really, I think we talk about time to balloon for, a heart attack and being able to stent their heart. I need to talk about time to BUP. How quick can I get BUP into this patient's hands and into their body? And it needs to be less than 24 hours. It needs to be, on the order of hours. Otherwise it's in their head and they have another solution to that. So anything that shortens how quick we can get the medications to them is really critical. The other thing for us is for jail in particular, they could be released at any time. So it's really hard for discharge planning there, even though we're in very close connection with our jail system, who does a great job actually with addiction. But they could be discharged or released on a Friday afternoon. And so where do they go now? Now all of our outpatient clinics are out of order, or not out of order, but they're not open. So I have to go to the emergency department. It makes it even harder if they're on methadone, for instance, because then you need a methadone clinic, or you're going to need an emergency department to be able to give it. Really creates all these barriers. Some of those long-acting injectables might give them a little bit of breadth of time to figure out some other stuff and figure out follow-up. But we also want to make sure that they're engaged very soon after release so that they know where they're going. So the problems are vast. The risk is astronomical for the patient's survival, for the community, for their family, for reincarceration. And there are potential solutions, but it's all about removing barriers, providing low threshold care, and being proactive and reaching out to these patients. It's really unreasonable to expect that they can navigate this system. Yeah.
I think that proactiveness is incredibly important. We funded a project in North Carolina with Andre Jones at University of North Carolina Horizons program, which is a women's residential treatment center where they provide daycare. You get an apartment for a year, you're in daily treatment, and the kids could essentially be, right downstairs through a number of different age daycares. The project that we funded was about meeting these women that are leaving incarceration at the door, pregnant women. And during the entire COVID, the project met 250 women out the door, and not a single overdose occurred during the 2 years of the project. So that gives you an example of the level of attention and care this population needs, but we know what we need to do as well. We just have to have the will to do it. And so I want to segue now a little bit into, we've been talking a lot about treatment, but on our call we talked a lot about prevention as well. And that being just as important, if not more important than treatment. We can't treat our way out of this. We're going to have to prevent what the next wave is. We're talking right now that we're in a fourth wave. There's a debate of whether we're in a fifth wave of an opioid crisis right now. So I just want to give everyone an opportunity to talk about prevention and how Medicaid can potentially help really stop that intergenerational addiction crisis that we have going on right now. So David?
It's often said, an ounce of prevention is better than a pound of cure. So we definitely have to intervene early. So again, the statement I made earlier about intervening in school-age children, educating them, and it has to be more than just say no, right? It has to really have some substance to it that they can carry with them. Just say no was great for its time. It was an introduction into having a discussion. But our kids, I always say my kids today are much smarter than I was when I was a teenager. They have access to so much more information. We have to have more substantive conversations with them. And we have to have substantive conversations with the children of individuals that are using substances. That's really an important population that we have to tend to. Several years ago, I had a teenage patient that came into the exam room, and his mother had passed years before of an overdose, and he was being raised by his adult sister. And he asked me, does the fact that my mother had a substance use disorder problem, does that mean that I'm prone to having that also? And the honest answer is there is a genetic predisposition. So I told him, yes, you have to make sure that you steer far clear of anything that is addictive. Not just opiates, not just cocaine, but we're talking about gambling, we're talking about sexual addiction. We have to have honest discussions with our children. And I oftentimes tell people that, but for the grace of God, go any one of us. Those of us that do not have a family history of addiction don't know what our genetic predisposition will be. So it could be just a short-term dose of an opiate for pain medication that could, spiral us into a downfall spiral of substance use. So I think education is key. Community programming is key. After-school programming. Many of our children are crying out for activities to be involved in, for things to do. We have to keep them busy. We have to let them know that education and employment is the way out of poverty. When the environment that they're living in is saturated with substance use and substance selling, it's really important that we interact and engage with that population very, very early. So prevention is essential if we're going to reverse this trend of annual increases in overdoses. We have to educate, we have to intervene. Substance use oftentimes starts early in life, and by the time we get to them, even at 20 years old, they've been utilizing substances for several years. So I think prevention is key. Early treatment is key. We have a youth residential treatment program, but we're also talking about doing more youth, even outpatient treatment, utilizing buprenorphine in some of the older adolescents early, rather than waiting for them to have a 10 or 15-year history of substance use. So prevention is key, early treatment is key, education is key.
And Shonny, do you want to share how Open Door builds in prevention services at Continuum?
Sure. I'm actually currently at a CATCA conference, the coalition of community coalitions across America, and we currently hold 2 SAMHSA grants focusing on prevention and moving into treatment. One is Partnership for Success, and the other is Youth and Family Tree. And really understanding that you have to go quite far upstream. We're realizing, and I've been doing this for a while now, that high school is actually too late. You've got to move up into middle school and even into 5th grade, and start those conversations early. And so we do a lot of work in training and equipping, I should say, parents to have those conversations and to understand what to look for and how to evaluate. At one of the workshops, the presenter showed this stadium for Alabama's football team. And it's a very large stadium, and it was fully packed in the picture. And she said, this stadium doesn't hold as many people as died from overdoses last year. And that graphic picture of what we're dealing with was so powerful. We have to get a handle on this. We have to be able to get ahead of this. And Daniel, you talked about trauma. The Body Keeps Its Score is my book recommendation by Van der Kolk. And it is so important that we understand and support families differently. Just having families have to come back for a different visit because you can only get reimbursed for one visit. I mean, it's important that we are able to bundle as many services and supports and minimize those barriers to accessing that care right down to the payer system and being able to fully reimburse for those things. It's incredibly important that prevention be reimbursed as part of this care continuum as much as treatment. It's not as fun to grab a hold of what as in terms of data and but it is in the long game going to really make the difference. I really encourage those conversations, not surface level conversations, really, drilling down to what's really going on. Our psychiatrist often says, if you just ask, do you drink? And I say, no, I don't drink. And we're done. I'm good. But meanwhile, I'm saying I don't drink because I just had a DUI last week. And so, no, I'm not drinking this week. But that is not the full story, just to say, no, I'm not drinking. So you have to become a more sophisticated clinician, a more sophisticated system, and really understanding that, we have to have different conversations. Our parents really don't understand the landscape of marijuana. Our parents really don't understand the landscape of fentanyl, and fentanyl being a part of marijuana and part of very pills that are mimicking things like sweet tarts and things that are so easily accessible. And and having all of that information just be part of a natural way that our parents understand what their children are facing, and having the kids better equipped to make informed decisions. I always say delay, particularly as you're moving into adolescence, delay. And I like that delay message because it puts the onus of control back on that child. It's not an external. Teens like to rebel against that external, putting those rules on you. And delay is something that an adolescent can do for themselves, because they know that that's my decision to delay use. That's my decision to say no. And that's not you telling me I can't. And so that delay message is a huge part of prevention.
Fantastic. Dan, I want to give you an opportunity on the prevention side, but I see we're running low on time, and there's one more topic that I do want to get to, and that is harm reduction. I'm sure that everyone has noticed that over the past few years, harm reduction has become the buzzword essentially within the continuum of care. But one of those things that we find is if we ask 20 different people across the country what harm reduction is, we're going to get 20 different answers. So I thought first, Dan, if you could introduce what harm reduction is and how H&H approaches it.
Yeah, so great topics to talk about here. Harm reduction is kind of comprehensive. We bring it into everything that we talk about, and now it's integrated into like my life in general. So if you're exposed to 10 units of harm, if we can make it 9 units of harm, that's great. And I think the term that I started using now all the time is acceptance. So if we accept where they are, and that allows them to start making change, which is interesting. You accept where they are, and now they're able to make those positive steps towards reducing use, or using slow, going slow, starting low, going slow is another one. I knew I'd get there. The other kind of classical ones in the addiction world is Narcan kits, fentanyl test strips, xylazine test strips now. All those, showing them where they can get safe, clean needles. In New York City, we have safe consumption sites, so meeting them right where that is. But also just, hey, if you're going to use, let's make sure that you're using with a friend. Let's make sure someone's there. Let's make sure if your supply is laced with anything. And so I kind of put that all together. Even if they're just engaged with care, I know they're even if they continue using at the same rate, all their other health things go better also. So their blood pressure is going to be better controlled. They're going to get their colonoscopy. They're going to get their vaccines. So it's really just accepting where they are, seeing what we can do to improve their risk a little bit more. I think on the treatment side, a lot of people say, hey, this patient's really complex, has co-occurring disorders, is also using benzos, is using cocaine, and they're also using heroin and fentanyl. Say, okay, well, there's all that stuff, but we can save their life by starting Suboxone right now, or Bupe right now, or methadone. So yeah, I wish they weren't using benzos. I wish they weren't using cocaine. But right now, that's not the issue, and we can do this. And honestly, if we can solve this, then they can start making changes on all that other stuff. As for prevention, I just do want to kind of Shonny's recommendation for The Body Keeps Score, great book. But also I think that's critical. And I just want to, Ken, your story of what you did for those pregnant women, you could think of that as treatment, which it is. For those women, it's treatment, it's critical. But what I think is so heartwarming, and what I think is beautiful about that is getting to the root of the problem. It's not just those women, it's not the individuals that you're treating, it's treating the family, and it's treating the community. And so when we address that, those children that are born to those 250 women that you saved and provided comprehensive care, really just incredible work there. But those kids are at way lower risk. You've just resolved and mitigated so much trauma that they'd be exposed to. And that's, I think, how we get to the bottom of this. And I also just want to throw out that trauma is not just about addiction and mental health, but it's also about cardiac issues. It's about pulmonary issues, rheumatological, cancer, all those things decrease. So if you're talking about bang for your money, go with childhood trauma, go with early intervention, because you'll not only help addiction, but you'll help everything else also. So.
Completely agree with you. Our prevention program actually comes at it completely from the basis of adverse childhood experiences and trauma. So that's what we focus on. We have projects in the Pacific Northwest as well as in Florida working with OTPs. We know that many parents that go to OTPs every day have children themselves. So what if we built in prevention services that the child could be participating in at the same time that the parent is getting treatment? And one of our scientific advisory council members, Hoover Adger, pediatrician at Johns Hopkins, he often says that treatment for the parent is often prevention for the child as well. So look at that, we are at 0 right now. So I just want to thank all of our panelists for this really engaging conversation. Like I said, I think we could talk about issues for days on end here. But thank you all for joining us. Thank you.
Thank you so much to Ken, Dan, Shonny, and David for this engaging conversation. We'll enter into our Q&A, and anyone that wants to ask questions in person can line up at the mics. Our first question is, what Medicaid reimbursement changes would make it easier for you to provide patient-centered integrated care?
Wow. So many. I mean, first and foremost, I think rates have to increase in order for us to be able to afford the workforce that we need to employ. We need an increase, I'd say, across the board in terms of rates. Reimbursable services, we talked about peer support services needing to have an enhanced reimbursement for it to be sustainable. The value of peers and individuals' lived experience is undoubtable. I oftentimes equate them to our translation services. Providers speak to a person in a room. If they speak a different language, you call a translation service. Without that lived experience, you can't speak the language that individual needs to be spoken to in. So the peers are absolutely essential. I'm glad that there was a lot of take-home flexibility that was implemented during the pandemic and that it's been sustained. That needs to be permanent. I don't think there's any question about that. I'm excited about the prospect of mobile methadone dispensing. We plan to launch. Actually, DEA is visiting our unit in the Bronx as we speak. So hopefully if they're listening, will expedite their approval so that we can get that out on the road. But I think we have to be innovative in our thinking. We have to have low threshold reimbursement. Even for residential services, if somebody's not going to commit to, say, 9 months of residential treatment, we have to be able to get reimbursed for shorter term intervention, because those short terms may make a difference in a person's life or in their family's life. So there's so many things that I think could be helpful. I think there've been great strides that have been made. So I applaud that from our regulatory and reimbursement agencies, but there's a lot more that we can do. I think integration and collaboration is key. So I'm excited about the future.
Great, and we can take an audience question.
Great, good afternoon. Thank you guys very much for the talk and the subject matter. Adam Aponte, Chief Medical Officer at the East Harlem Council for Human Services. One of the things I reflect upon in the discussion is the sort of formerly incarcerated individuals and getting out. And I think the way you should look at these individuals is transition of care, right? It's same as transition of care from any other setting. When you leave a nursing home, when you leave an inpatient setting, rehabilitation. And so I think that's the way we should start to frame these individuals, because they're in the same sort of vulnerable states, that those initial 30 days that we understand for those other transitions of care. And I guess my question, and maybe this is for Dan, because I know you do a lot of work with this population, is prior to these individuals being released, what kind of sort of, you say that it's easy to turn the Medicaid back on, but prior to being released, is there not an opportunity for the health system within the prisons to provide this individual with medications for a 30-day period or something along those lines, so that gap, they don't have that gap? Is there something in place for these individuals?
Yeah, thanks for the question. First of all, I just buy into the transition of care being a strong connection there, and just all transitions are a moment of high risk for individuals, whether it's from the hospital to the community, from incarceration to the community. So that's really critical. And also just thinking about how we can build in buffers on both sides, because things get dropped. And if these things get dropped, again, we know what the patients are going to turn to because they have an easy solution. In our situation, we were very fortunate that we work very closely with the correctional health system. And they try really hard to get them. They'll put in for a Suboxone script for 2 weeks. The problem is they don't know when they're released sometimes. So they have to kind of predict it ahead of time and say, okay, which pharmacy do you want us to send it to? That's really tricky. And you do that at intake, which is great. The program I'm talking about is KEEP, which, there's research published on it. You can look it up. They do great. And they do it at intake. But then, a week or a month later, is that individual going to remember what pharmacy they said? Is everything going to go through smoothly? Because you can't say, okay, you're going to be released tomorrow and we'll be able to do that. And that's just on Suboxone or buprenorphine. Methadone is even more tricky. With methadone, they'll make sure that there's an outpatient methadone clinic that's ready to accept them. But what happens if they get released on Friday evening? Well, now it's getting more tricky. And so we do have communication, but it's really tough for them to have, what I would normally think of as discharge planning, which needs to be comprehensive and thought out, to they're just like, okay, I guess they're released. And that's really tricky. So that's an issue that certainly needs, integrated work about. But we communicate with them. We have kind of, we know who's available, and we have walk-in facilities available at H&H, that Health and Hospital, that increases their ability to get care. But it's tricky if it's a Saturday night, they're not going to be able to get that.
Just a quick follow-up. I guess my real push is for the dispensing of that medication, not the script, before that person leaves. Is there a possibility to dispense the medication prior to the departure is really what we should put our thought on.
Yeah. I mean, I think to me, I would totally agree if that was possible. I leave it to the correctional health services to be able to tell me if that's possible or not. But I think they've, at least here, they've really looked into it a lot and have not found a solution to be able to dispense it to them, because they just go to the court when they release, and now you're good luck, So I think that's a multi-departmental conversation. But I know we have the providers who would love to be able to do that, and I think it is necessary. Or even just give them the injection, like the Brixandi for a week or Sublocade for a month. That gives them a little buffer.
I'll just add quickly that we found the project during COVID with the University of Maryland, and the entire idea was to be able to deliver and dispense medications for opioid use disorder within state prisons, and through telehealth, basically connected to the University of Maryland, and they were able to get that up and running, pretty quickly. Granted, Maryland had a state requirement that was going to go into effect, I believe, in January this year, that required all jails and prisons to provide all FDA-approved medications for opioid use disorder by January 2023. So it's possible, and the outcomes that they have seen and been able to track those patients outside once they are released, it's incredibly exciting to see the effects on it.
Our next question is, are you encouraging patients to utilize buprenorphine over methadone? And do you expect this to lead to encouraging less frequent utilization of comprehensive treatment centers?
Well, we spoke about meeting the individual at the point of their need. So I would say it's really patient specific. Buprenorphine is great for some, methadone is great for others. So I don't say we encourage one over the other. You really have to look at that person's individual situation, their history of use, the accessibility of the outpatient treatment program. So we prescribe buprenorphine to thousands of individuals. We have hundreds in each of our methadone programs that are on methadone. So we utilize both and tailor it to the specific needs of that individual. But I would never say I side with one over the other. It really is individually based.
If I may,
go for it then. I think we're going to say the same thing. So.
I'll just go ahead and say this is a little bit of a hot take here. I mean, definitely you meet the patient where they need. But I do encourage bup a little bit as first line. It would be my choice Again, it doesn't meet the needs of everybody, but that ceiling effect, no one's overdosing on buprenorphine versus methadone does have a few thousand people overdosing and increasing doses, especially in the elderly who have been in methadone for many decades. That same dose has a bigger effect on them. Now, that being said, methadone has been around forever, so I'm not looking to like rock the boat with those individuals. So that's really critical there. But the other thing I'd like to throw in there is a huge racial discrepancy between methadone and buprenorphine. And we're seeing that it's time and time again. I think I hope we don't, to the question, I hope this doesn't lead us to less comprehensive care, because I think that, you do want, some people need that daily check-in or the more stable follow-up there versus bup, which is usually weekly or monthly, and doesn't have the support systems in place. So I hope that's not the answer, but I do predict that methadone continues to like slowly trend down a little bit, while buprenorphine, I hope, picks up significantly. But whatever the patient needs, whatever they're going to take right now, and Vivitrol is another one, but that's kind of a third. That's actually, even third in my list. But whatever the patient wants, I'm happy to get them.
Hi, I'm Caroline Lewis, a reporter with WNYC, and I also have a question related to people who are incarcerated. Like, I know a few years ago there was this understanding that it was actually easier to get buprenorphine if you were in jail in some cases, and that was like a major prescriber of buprenorphine. Like, given all the issues going on at Rikers and things like that, like, is it still common for people to get buprenorphine there? Like, is it trending in any particular direction in terms of like how frequently that happens or accessibility?
Yeah, just because it's Rikers, I'll take this one. Yes, they're continuing doing it. Rikers actually does a really great job. The KEEP program, I would refer you back there. They do a great job, and anyone who wants to, who screens positive, can get access to care, including buprenorphine. So they do a great job starting people on it, continuing people on treatment. And then the biggest concern is that transition. It's just a really high risk time. So yeah, I'm proud of what Rikers has done for addiction, to be honest.
And we'll take our last audience question.
I don't have a question, but I have a shameless invite to a prevention awareness day that the Citywide Addiction Support Network is putting on next Thursday. It's going to be in the FDR Park at the end of 10th Street, and it's a culmination of 22 providers and health and hospitals who are working together under a opioid response grant. We're putting together an awareness day to bring to the public's awareness about xylazine. This is a outshoot of the work that the peers, people with lived experience, they demanded to do something about this. They felt they couldn't wait for anybody else to do something. So we put it on three awareness days, and the one in Manhattan is next Thursday. I encourage anybody here to go to that. You'll be able to meet with peers, you'll be able to meet with the providers, you'll be able to learn about educational work, about xylazine. There's also food, there's music, there's entertainment. 12 o'clock to 4 o'clock next Thursday, and I'd invite everybody to come. So please join us. Thank you. And thanks for the panel.
Thank you.
Thank you. We will now take a 1-hour lunch break. We want to remind everyone to fill out the session evaluations. For those on Zoom, those will pop up. For everyone else, those will be open through the lunch hour. For those in person, please join us upstairs on the 3rd floor in the reading room, where you can pick up a boxed lunch. And that's accessible by using the elevators in the lobby or the stairs. We'll be back at the main stage at 1:30 p.m. For our afternoon session. Thank you.
Hello, everyone. I hope you enjoyed lunch. I'm Alex, the director of the Medicaid Institute with the United Hospital Fund, and it is my pleasure to welcome you to our next panel, Challenges in Providing Primary Care to Medicaid Members. And I'll start with some brief introductions, but do remember that the bios of our esteemed guests are on our website. I'll start with Adam Aponte, who is a pediatrician and the Chief Medical Officer of Boriken Neighborhood Health Center, an FQHC serving the East Harlem community. Stephanie Wang is a primary care physician and Senior Medical Director of Care Transitions and Population Health at Mount Sinai Morningside and West Hospitals. And Paulo Pina is a board-certified pediatrician and the Network Pediatric Medical Director of the Family Health Centers at NYU Langone. I'd like to start by having you each describe a little bit about your practice and the patients that you see in your clinics.
Is this on? So good afternoon, everyone. This is call and response here today. And we have a tough task today because we have you guys after lunch. So what we agreed to do is a little dance. So you guys ready? Oh. But anyway, we hope to keep you guys engaged. So first of all, I want to say thank you to the United Hospital Fund for inviting me to be a part of this panel. Today is I'm also very proud of my colleague, Dr. Oxiris Barbot, who is now the CEO at the fund. So happy to see her. Oxiris and I came up together. I met her over 25 years ago when she was in school health. And it's wonderful to see a fellow Latina, Boricua, representing. So that's what's up. So as mentioned, I run the Boriken Neighborhood Health Center. The corporate name is actually the East Harlem Council for Human Services. And this is an organization that's been in East Harlem for over 60 years now. Started as a social servicely minded organization focusing on sort of social issues that impacted the community. And that traditional grassroots effort, folks came together and asked, what do we need in our community? Focused on some of those issues, and then quickly understood that healthcare was an issue for East Harlem. And despite the fact that we're surrounded by many hospitals, like Mount Sinai, Metropolitan, Harlem Hospital, at one time, North General Hospital was here, there was awareness that the availability and access to healthcare was very limited. So they created the Boriken Neighborhood Health Center almost 50 years. As a matter of fact, next year we'll hit our 50-year anniversary. Stay tuned for our gala invitation. And so we are a FQHC, Federally Qualified Health Center. We fall under HRSA, and we provide all primary and preventive care services. That's our focus, primary preventive care services, and serve anybody who walks through our door, regardless of their ability to pay. Immigrants, we had a big influx of sort of migrants that came in as of recently, that came to our health center. And we provide services from what I describe from womb to tomb. Everything from prenatal care, pediatrics, adult medicine, behavioral health services, and then, we pride ourselves on being a health center. Oftentimes people call us a clinic. I don't describe us as a clinic. I think for those of us who grew up in this neighborhood, know what clinics were like when you went to Metropolitan and Mount Sinai, and I could talk about them because I was born at Metropolitan and I went to medical school at Mount Sinai. And grew up 4 blocks away from here. But we know what that experience was like, right? You went into the clinics, you came at 9 o'clock in the morning to try to be the first patient seen, you waited 3-4 hours, no one ever spoke to you, you saw the physician for 10 minutes, and then you left. You need a referral specialist, you were on your own. We do a lot more than that. We hold our patients' hands, and we really help them to navigate this very complicated healthcare system that we all know is very complicated. And even for those of us who are well-educated and well-resourced, find it to be very complicated. And so we'll talk a lot about that today in terms of what we do to really help them navigate that and sort of really address all the issues that were addressed this morning by Amir in terms of those what I call social issues of health, influences of health. I don't like the word determinants. To me, I'm a pediatrician. Words are very, very powerful. And when you say determinants, it denotes inevitability, right? This is going to happen to you. And when you say that to someone who lives in a community like this and you say it's determinant, they feel that there's no hope. Like, regardless of what I do, I'm gonna face these issues, and these issues are gonna affect my health. And growing up in this hood, as I did, and experiencing the food insecurities, the high poverty rates, the crime rates, all those things, here I sit before you. So I describe them as influences. And this is something that FQACs have been doing forever, and we'll talk more about that today, but really happy to be with you today and engage in this conversation.
I am actually really grateful to be here. It's an honor to really just share my perspective on how we as New Yorkers struggle with taking care of our partners, our friends, our family, our community. So I started at 147th Street in Central Harlem, and the goal around that practice was, because it was sort of like it was a HIPSA shortage area, and we wanted to really be in the community. And it's through that experience that I really got to meet the community, know what their needs were, and, you know, kind of leverage some of my primary care experience. So I trained at Bellevue at NYU as well. So to really connect people. And that's one of the biggest struggles, you know, for primary care doctors these days. It's like, how do we do it all? How do we balance everything, make sure that you take care of all those clinical needs, and then on top of that, make sure that our patients have the food that they need? How do they get to their appointments? How do we help them balance all of the stresses in their lives, get them the behavioral health that they might need? Is the system set up well? So we did a lot of social needs assessments, and I'll borrow Adam's word to really find out about the social influences and see what we could do as a health system to really connect people, because my health system really does feel strongly that this is something that we can help our patients with, and it will raise the health of the whole community if we actually take that step beyond our walls. I currently practice at West 91st Street and Columbus Avenue, and it is a very similar primary care practice built specifically to take care of all comers. So we are as payer agnostic as you can get. I have patients who have Medicaid. I have patients who grew up on the Upper West Side. I have patients from Central Harlem who followed me. One of my colleagues has patients all the way up to Washington Heights and Inwood. And so we take everybody. And, you know, in my particular role as the Senior Medical Director of Care, Transitions, and Population Health, I partner with all of our primary care practices and beyond our walls with our Ryan Health Network, who is our federally qualified health center. And so we have an in-depth idea of all the different social influences of our community and how we can truly make a difference.
All right. Good afternoon, everyone, and thank you to the UHF for inviting me today. This is a full circle moment because I work at a community health center. I grew up receiving care at a community health center in a community that's predominantly immigrant. I'm an immigrant. And so currently I'm at the Family Health Centers, which is one of the largest FQAC networks in the country. And we serve communities in Brooklyn, mostly immigrant. New immigrant community, but also a lot of working class communities. The majority, specifically kids, are in government-based insurance, and a lot of our families and parents are uninsured or underinsured. And so our mission is to take care of everyone, regardless of their ability to pay to see us. And we run a network. We have multiple practices in Brooklyn, but also proud to say that I oversee a large network of school health programs, which we believe is an integral part of taking care of our children and making sure they're in a setting where they're learning and becoming healthy. So it's a great opportunity to come here and talk about how we stop the old adage of doing more with less. We need to move away from that because we are passionate about the work that we do, but we also need the resources to do that.
Great. And I want to start with you, Paulo, for this next question, but everybody will have a chance to answer. What challenges do you experience working with patients who are on Medicaid compared to those who are not?
Okay.
Keeping it on Medicaid for today.
That's okay. Multiple. Like I said before, I'll go with top three that I could think of. One, we are taking care of families, and we are taking care of families that are under-resourced. And we would like to take care of our families. We would like to take care of the whole family. Not just the child and ignore the family, ignore the parents, because they might have issues as well. So, and we all know about our social influences, and we are doing the work. We are screening. We are referring to community resources, but it takes a lot of the resources in terms of operational resources to be able to provide these services, and a lot of these services are not compensated by insurance. So that makes it difficult. We have, we are in a working class community. Our families work. And to come see us, a lot of times they have to take off of work. And they don't get paid for those days. So it would be nice if they could see multiple physicians in the same day. Specialty visits, we have a lot of kids with chronic health needs, and a lot of times their reimbursement structure is different if we want them to see our asthma specialist at the same day. So parents, again, have to come back and miss another day of work to be able to do that. And that affects all of the other components. It affects rent, affects food. And we're happy to be there to help, but it also puts an increasing burden on our families. And also just wanted to mention our behavioral health. We know it's a crisis, especially in children. It would be wonderful if we moved away from the model of, treating diagnosis and moving towards pediatricians. We believe in preventive health, preventive behavioral health. Covering for those services would be really amazing. And don't forget about our young adults. As someone who runs a young men's clinic, who happen to be a lot of new immigrants as well, it's a big burden. It always breaks my soul when at 19, they're no longer covered by any form of insurance. And so we have to figure out ways to make sure, especially our kids that have special needs, how are we gonna get them their medications? We want them to go to school and learn English and start working to, get a better job, but they can't do that because they can't afford to see us, because it's still not free care. The medications are still not free. We have a sliding scale, but not all of that is free. So there's a lot of challenges that we really, really need to address, and we need to address it quicker because society is moving quicker than we are addressing these things.
Stephanie, anything you want to add to that from your perspective, working mostly with adults?
Well, it was a very heavy question. I think for me, one of the biggest challenges is that care coordination piece. And, as Paulo mentioned, we're dealing with the whole family. And in the adult perspective, it's like the daughter, the son, the spouse, and the grandkids too. And so often it's getting them those resources and then getting that coverage for those resources. Because it's the hardest thing for a doc to say, oh, this is not covered. What do I do with this? I know that you need X, Y, and Z, but I myself am not able to provide that. Our health system has been very fortunate that we've partnered with multiple community-based organizations to help that, but not every primary care doctor has those connections, the social work to take care of this. And in many ways, it's like, to even have a social worker is like such a blessing to us, right? To have a case manager at the tips of our fingers, to go and tap them and be like, I need your help. It's hard for doctors to say this, I need your help, but that's the reality of things. I cannot do this by myself, right? And the patients cannot do this by themselves. I think that sometimes in adult medicine, we think, oh, they can take care of this. They've got resources, right? That's not true. I mean, we've made social services and healthcare so complicated that it takes hours for them to figure out, is this covered or is this not, right? I think one of the biggest challenges for me is also funding all of these things. I think on a big global level, we know that social services are very important, but when I have to go to my budget people and say, we're doing all of these social needs assessments, they're actually having all these actionable items. Look, there's even outcomes. It's still a challenge to cover it because in their minds, sometimes this is outside of the clinical, right? And never mind the community-based organizations that are also struggling, right? They're all grant funded. And so in our minds, it's like they went and got a grant and now the grant funding's running out. What do we do with that, right? And then, you sunset a program. So how do we, from a more community-based circumstance, from a more legislation perspective, help fund all of these really valuable services so that we can improve community health overall?
Yeah, so I mean, Claudia, echo, ditto on everything my colleagues said. This is the big challenge for us. I mean, and we're in a unique position as an FQHC because we have double regulations, right? So we're very highly regulated in terms of what we're required to do. And somewhat rightly so, we get federal money to do the work that we do, not that it's adequate enough to cover the cost of everything we do, but you know, the feds want to know what we're doing with their money and how do we sort of applying it and focusing on it. So, you know, when you look at communities like the ones that we serve, so we serve predominantly East Harlem, Central Harlem, some of the South Bronx, you look at the individuals, we know all the stats, right? We know all the issues that this communities face. But one thing I want to say though, before I go into this, is that this is a very resilient community. We often frame this community as underserved and challenged and all that stuff, and we talk about all the negative things about them. But something I learned about recently is sort of asset framing, to talk about all the things that this community does great. And they're very resilient, they're very resourceful, they're very community oriented, they want the best for each other, and you know, we oftentimes don't recognize the challenges that they face and how they overcome these challenges. So I want us to be mindful of that as we talk about these communities, because it's not all bad, but clearly there's a lot of sort of other things that are impacting them in terms of their care. And when you walk into a health center like ours, where most of our patients are Medicaid, I think 65-70% of my patients are Medicaid, small percentage are Medicare, including duals, and then we have probably about 9% who are totally uninsured, although with some asylum seekers, that number has probably increased. And when these folks come in, they don't just come in seeking medical care. Right? If that was the only thing they wanted, if they only needed treatment for their asthma or their hypertension or whatever, we probably could do a pretty decent job of caring for them, although, again, the social influences that impact that, we don't know how to mitigate. But they come in with all kinds of trauma. These communities have faced trauma all their lives, right? Dealing with these issues in the communities that they face day to day. And that comes out in the exam room. And so we as FQHC feel obligated to addressing these issues by whatever means we can. And so when you heard this morning Amir talking about sort of food insecurities and all these other things, we have been addressing these issues for many, many years. We have a food bank at our health center. We have a food pantry that we've created. We have clothing drives that we give our patients. We have health navigators that we don't get reimbursed for. I have care managers that work with my patients that don't get reimbursed for. And so all these things are not reimbursable under this current model of Medicaid fee-for-service. And I say this often, that Medicaid fee-for-service is dead. If it's not, we should kill it, because it is not the way that we should be getting paid for the work that we do. Because there's a lot of work that I can do with other types of individuals. They can keep a patient out of my health center, but equally address their healthcare needs without having to see a visit to earn money, right? If I don't see a patient, I don't earn money. And to Paulo's point, you know, if I give a patient 2 visits a day, I only have 1 threshold visit. So I only get paid for that 1 visit. I can do it, but it's at my cost. And so unfortunately, while we want to do the right thing for our patients and try to decrease that, because we don't want to drag them back the next day or 2 days later, we know that that's a burden upon them. The way that this fee-for-service model is structured, particularly for us, does not allow us to be innovative. You cannot innovate in a fee-for-service model. And we need to innovate in the fee-for-service model. We need to have more of what you heard this morning, community health workers, community liaison workers, people who go out and work with individuals, help them navigate. I have a patient navigator that literally takes patients to appointments because they don't speak English. And they want to make sure that they get the care that they need. And you know what we do? We send them in an Uber Health. That, again, I don't get paid for, but I had to apply for a grant, which fortunately we got, to help my patients with transportation. And although New York, you know, compared to sort of upstate New York, right, transportation is a little easier, but it's not always easy to navigate, particularly when you're a new immigrant, you don't speak the language, and then when you show up there, no one's helping you navigate that complex healthcare system, right? You show up at Mount Sinai, you got to go to, you know, the Abrams building or whatever, you got this maze of hallways on the, you know, lower level there that you have to navigate, and it's not like someone shows you how to do it. So these are all the things that we try to do to hold patients' hands and navigate them, but we're not getting reimbursed for them, right? We're not getting any sort of, you know, compensation or offset to the cost that have it. We're committed to it. We're going to continue to do it because it's the right thing. And so that's why we're sort of more focused on this value-based contracting process and focusing on the quality of the care that we give, not the quantity of the care that we give, and so that we can really spend a lot more time with our patients, and that we can add other care members to the care team. They will also have an equal impact on their care outcomes, their healthcare outcomes.
Great, thank you. And as something that has come up, obviously you all have touched on how critical having a relationship with a primary care provider is, and how much you work to build trust with your patients and your communities, and how you work with these people throughout different phases and stages of their life. And that was something we saw during COVID-19, that having a primary care relationship was absolutely critical in that response. But we also saw that many people didn't get their routine screenings and are still not getting back into care in the way we would hope. So Stephanie, I want to start with you. What are you all doing to try to get people connected back into care and get them caught up on those routine screenings?
That's a wonderful question. So I actually started during the pandemic, because we realized that we were doing a lot of phone outreach, and we were offering telehealth because we couldn't have a lot of patients coming in at the time. And we recognized that there's not as much access to things. Like, you would think people might have an iPhone or a smartphone at this point, but the particular medical record that we had, you needed to have a specific iPhone. You couldn't even just have a laptop, right? Never mind the people who don't have an iPhone, which is a vast majority of people, right?
I'm Android.
Right? So what we ended up doing was just cold calling all of our patients and reaching out to them and saying, I'm calling from your primary care doctor's office, and we want to let you know that we care about you. And we understand that there have been so many different changes in your life. And even though you're stuck at home, we want to be able to offer you whatever services we can give you at this time. And that's sort of continued, actually, since then. I think many of our patients were like, I'm so glad that you met me where I was at. Meaning, you talked to us, you allayed all of our concerns and our worries. You actually got me behavioral health because I really needed to talk to somebody, and it was actually telehealth at the time, which was pretty cool. And so even right now, that's what we're doing. I think it really kickstarted our outreach, in the sense that we do a lot of proactive outreach now, trying to remind people that, we really care about you. We know that you missed that breast cancer screening, that colonoscopy. How can we help you get that in, as soon as possible? We really care about your health, right? So we'll find a way, and we'll set it up for you. We'll remove all the barriers. We'll even schedule it, and we'll send somebody to help you get there.
Paulo, anything you want to add?
Yeah, obviously there's been a lot of changes that needed to have been done to keep up what was happening in society. But I think one of the important things to always remember is, once they trust you, they will come to you when they need help. And the amazing thing about being embedded in the community, sometimes, we're 2 blocks away, that they can access us, and having our doors open is really important. But we also had to work harder, because there were segment of our populations that just didn't come in. So it's a lot of outreach. We used technology a lot to reach our patient. There's always this misconception that our communities don't use technology, internet, to communicate with us, which is just BS. We have some of the highest, I can tell you, in my pediatric practice, in our whole network, we have over 90% of our families enrolled in in their patient portal, and about 70% are actively using it. And so we use that a lot to communicate with our families, and then we also use texting programs. Our immunization rates are some of the highest in the state, because we text families about the importance of immunization in a language they prefer. So our communications are sent in English, Spanish, and Chinese, depending what their preferences are. So it's really, being there for the community, developing that trust, realizing that we are not going anywhere and we will meet you where you are, and provide you whatever you need to get to the next step.
Yeah, and this is actually, I'm going to scale up this question because I think what COVID did was something that we all kind of suspected in terms of, further increase these health disparities that these communities face, right? And certainly so we did a lot of work, of course, to try to re-engage people into care and bring them in, and there was a couple of particular measures and sort of gaps in care that we focused on, the cancer screenings, right? Cervical cancer, breast cancer screening, colon cancer screening. We wanted to make sure people brought in. But what we also understood is that, even based upon our different communities, right, there's a different approach to these communities. And when you talk about a healthcare system in New York City or New York State, what we need to understand is it's not one size fits all when it comes to this. And when we need to do things like a COVID response, a vaccination response in East Harlem, what we need to do is have a partnership with our departments of health and let us lead the way. We'll show you what needs to happen in order for us to reach our communities. Because again, during COVID, we had to make a lot of noise to get vaccines in our community, and I was very, very vocal around this. Because I knew the Doña from across the street at Taino Towers was not going to go to the Javits Center to spend 3 hours online to get a vaccine from someone that she doesn't know, doesn't trust, and doesn't speak her language, right? And when there's all this stuff going around. So I think another thing that we need to take away from this is, as we have these approaches to improving the health care of our communities, talk to the people on the front line. Let us help guide that policy, that process. Let's not have this one-size-fits-all sort of approach, and trust that we know what our communities need. Your community happens to embrace technology. I will tell you that we struggle with telehealth. Many of our communities don't want telehealth. It's like that old school, like, I want to see somebody in person, right? It was like when we used to go to the Medicaid office, face-to-face, right? It was face-to-face. Everything was face-to-face. They want to see people. They want to build that trust. And then maybe they'll embrace the technology, but they're not going to go to telehealth without knowing who's on the other side of the line. And then teaching them how to do that is another thing. So each of our communities have a different nuance in terms of how that is adopted, accepted, and implemented. And when we sort of look at this from a Department of Health standpoint, State Department of Health, they need to utilize us in terms of guiding that process so that we can reach our communities, because sitting in Albany, you're not going to figure out how to reach people in East Harlem. Thank you. I got one fan.
It's great. And I want to go back to you, Adam, and pick up on a couple of things you've talked about related to doing more localized needs assessments, getting more community engagement, and also related to VBP funding and some of the health-related social needs. All of those things are themes in the next 1115 waiver, the NIHR waiver that Amir talked about this morning. And I wonder if you see some opportunities to make some of the improvements you're talking about in that waiver, and if you could talk about some of those things.
Yeah, I mean, it speaks to exactly what I was saying about earlier, right? Is that fee-for-service model that we don't get reimbursed for the things that we already doing, right? And so in this 1115 waiver, there's an opportunity to address those social needs that we have been doing for many, many years and get some reimbursement around that. And we're very well prepared to seize upon that, because again, we've been doing it, by hook or by crook, we do it. And we partner with other organizations and we bring in all kinds of partners to try to achieve that. But now we have a very structured financial model where we can do this. It's also sustainable, because when I do something on a grant, that grant runs out, right? So I hire someone, they come in, they do some great work. 9 months later, a year later, the grant runs out. Now I have to release the person because I can't sustain them on my on our operating budget, and the program goes away. So we did some good, and I'll take it. I'll do some good for a year period of time, but I want to sustain these efforts over time, and that's when we're going to get the return on our investment. That's the true prevention, right? It's not putting this Band-Aid on something. It's having a sustainable model and partnerships that make sense, that everyone can really be, sort of lean in as much as possible and be truly patient-centered. We talk about this patient-centered, model, but are we truly patient-centered when we have people running through all kinds of hoops and not being able to access? And these things are critical to preventive care, right? Because you have a diabetic patient who's homeless. They're not worrying about where their insulin is. They're worrying about where they're going to lay their head, right? And so that's not their priority. The hemoglobin A1C is not their priority, right? It's staying safe. They have food insecurity, so we have a diabetic. You need to eat healthy. Well, where do I get healthy foods in this food desert of East Harlem? We only have one supermarket serving the entire community, right? So now having these 11 to 15 waivers that are going to allow us to address that, partner, because we don't try to do it all. And as FQAC, we can't do it all. We really can't, and it's not our wheelhouse to do that. We want to provide the primary care part that we know how to do really, really well, and then connect with partners that can do all the other stuff and do warm handoffs to these individuals. And having a financial model that supports that is going to be critical to sustainability of something like that.
Anything to add?
Yeah, absolutely. I mean, one of the things that, as I put myself in the shoes of some of my patients and they come out of a hospital, how many different people have we now set them up to see? Never mind the specialist, visiting nurse, a community-based organization who's like a health coach of some sort, and they still have to go home, figure out how they're gonna get food, how they're gonna pick up their kids, or take care of the elderly parents. Never mind pick up their meds, right? And take care of their A1C or whatever reason they were in the hospital. And I think that the 1113 waiver gives us that opportunity to really streamline. And I'm talking about not just optimize it, but really just make it simpler, right? In the sense that one of the biggest gaps here is information technology and data, right? We have so much data, and every single person that I just talked about essentially has a care manager or case manager who's doing the exact same assessment all over again, right? This doesn't serve our patients. They're probably like, don't you know this already? I mean, for the clinicians in the room, we're like, oh geez, I'm so sorry, right? Like we kind of feel like, we got egg on our face because yes, we've asked the same question 16 times already. And they're actually really in their minds going like, so when's something gonna get done, right? So I feel that this 1113 waiver has the chance of making it easier for the patient, who in this case is the customer, right? It's their lives that we're stepping in and consulting on and helping out. Let's not make it so complicated for them.
The only thing I would add is just, we haven't approached it yet in this panel, but the work that we're doing, working with our families, addressing their social needs, it really leads us towards, we say we want an equitable system. Well, we're not anywhere near that, and equity will cost money. You got to put in the resources to get the things done that we needed. It's not going to be cheap. We have to do that upfront investment. We look at everything around us costs more. Everything with the inflation rate. So it costs more to do all of these services, but we're still getting reimbursed at the same rate pre-pandemic. So we really need to move away from that. You want amazing quality, we can get you there because our patients trust us when we talk about it's important to get this screening. They will do it. If we can provide you the high quality of care and the equitable care that everyone desires, but it costs to get there.
Can I just add something on the quality, because I want to jump on this, Paulo. There's something called UDS measures. I encourage you guys. What we do, Paulo and I particularly, because we work in FQACs, everything we do is transparent. Our quality data is out there for you to see. And I would dare say, and I know Paulo's CMO very, very well, and I know his focus on quality. If you looked at our quality scores, they would match up with any academic health center you find. Yet we do it on a shoestring budget. We do it in ways that no way the academic could ever do it. And outpatient care and ambulatory care is our bread and butter. It's what we do every day in all that we do. And so when you talk about primary care and prevention and focusing on, resourcing this is where the resources need to go, because that's what we do well. Let the hospitals do the surgeries, let them do the specialty cares that they do really, really well. When it comes to ambulatory care, outpatient, primary preventive care, that's all that we focus on every single day, and our measures match up with any academic health centers, regardless of how many world-renowned providers they have on there, because every hospital has world-renowned providers.
No, it's great. And I want to stay on this theme of quality and how it relates to the waiver. So this morning, Amir mentioned that they are looking to leverage the PCMH certification, which I know you all have at your clinics, to increase the reimbursement rates for primary care. And I'm hoping you all can just, I know we don't know a lot about that model yet, but I'm hoping you all can just speak a little bit to your experience as a PCMH and what you think about leveraging that to further enhance those reimbursement rates.
Yeah, I'll start off, first of all, our health centers, right? We're centers, not clinics. And so PCMH, for those of you who know, patient-centered medical home has been around for many, many years. We've been doing it. And I'm a fan of PCMH. I think that it really has held us responsible for providing true patient care, patient-centered medical care, right? Holding us accountable for the quality of that care, you know, and it's the right thing to do. And we were doing it, by the way, before PCMH as well. You know, patient-centered medical care actually goes way back, and for pediatricians, they know that Pediatrics was actually the founders of this because they had these children who needed a lot of care, and they started to center all the care around these developmentally disabled children. You know, this is going back, you know, 30 years ago or more. And so that concept of being patient-centered is something that we fully embrace, and we think that not making patients jump through hoops to get the care that they need is essential to help them navigate. And so the enhancement of rates and reimbursements with that, and a PM to do some other stuff like care management is essential. So we welcome the opportunity to get additional reimbursement for the things that we're already doing to allow us to do more things that we can't do because we can't afford. So I applaud that. I hadn't learned about that prior to being here this morning. So if I got nothing out of this conference, I learned about that. So I learned a lot more, by the way, but certainly that resonated with me a lot. And as I go into my next cycle of recertification, which I'm on a conference call next week to talk about already, right? Because it's a whole year-long preparation. But I think it's been a wonderful model. It really has helped us to hone in on those things that are really important. And for those of you who are not familiar with it, you know, it's referral coordination, right? It's follow-up after ED visit, after emergency room visit, after inpatient visit, right? It's answering calls after hours. Those fundamental things that patients need is what patient-centered medical home hold us accountable for, and rightly so, because patients need access to care at all times, and so we're doing it already. So yeah, I welcome the opportunity.
No, excited about it. I just want to make sure the rate is appropriate because we just should not be shortchanged because of it. But because again, the work, you're getting the quality. You are getting the quality, and our patients are healthier, and so make sure you pay for it.
I was going to say, although Mount Sinai overall may have a lot of funding, Morningside does not have that much funding. So I feel you. I actually do feel like whenever I have to go to my COO, it's almost exactly the same. They're like, do it on a shoestring. They're like, you can pilot it, go ahead. I actually was told by one of my department chairs, why don't you go apply for more grants? And I'm like, okay, I can proof of concept this. I thank you for the recommendation. And I think that's what all of us have been doing, right? Because PCMH has given us such an opportunity to transform our practices. You know, we have been doing the quality, but now we're standardizing it, right? In the sense that like, there's so much variability among all of our different providers. They've been trained in different ways. And PCMH actually gave us the opportunity to say, well, no, there's a good way of doing this and a way to save money to do this and this actually improve quality without doing all the bells and whistles, right? How do we risk stratify? How do we get our patients what they need when they need it? And not just because they have to wait for Dr. Wang to see you in 3 or 4 months. So it's given us so many opportunities to really transform medicine. But at the end of this, how do we pay for it? So I really think that we're doing the work. We've put in the investments, but we need to sustain them. And it can't be just on grants.
I mean, just to pick out on grants, right? So grants is not an easy thing to do. I don't know if you guys have written grants, but we don't have a grant writer on our payroll. And that takes a lot of time and effort. So when we're writing grants, it's us taking time away from something else to try to get that funding to support this. So, I'm spending time writing grants. I have directors who are spending time writing grants and trying to chase that. And it's not sustainable. And many of us can't afford to have good grant writers just to even write the grants. If any of you want to volunteer, if you're a grant writer, holla at me.
And I want to transition a little bit to something else that was talked about this morning, which is the unwind. So for those Medicaid members who are having to redetermine for the first time in several years, Paulo, I'm going to start with you and talk about what you're doing to outreach to your patients and what you're seeing in these initial months.
Yeah, so fortunately, we haven't seen a steep drop-off in coverage so far. We've been proactive at every visit, talking to our families, especially at the check-in process. Our support staff has been amazing, sending messages to, again, electronic portals have been very useful in getting messages to our families. So luckily, so far, we haven't seen a steep drop-off. There's occasional things, but speaking with our frontline staff, it has not been a big issue thus far.
Yeah, so I'll just speak. So we did a campaign, right? We make sure that our community was not ignoring these notices, because oftentimes they go ignored. It's been a long time since they have to recertify. And so we actually put samples of the notices that you're going to get up on our walls. We put the resources. There was a lot of sort of literature and sort of postings from the DOH that we actually borrowed and put into our health centers. And then we have, MCOs that we work with, partners that we work with as well, that come into our health center and sit at a table. And for patients who have, I'm going to use health first because I see my colleague Susan Bean here today, a great partner of ours. They'll have someone who will help that patient with the reapplication process, because it's a very daunting process. So imagine again, you're not English speaker, you have this application. A lot of this stuff is online now. You can't just do these paper forms anymore. You have to go into the sort of portal now to do all that stuff. A lot of folks don't know how to navigate that. So what we did was a really concerted effort to make sure that every patient's aware of their recertification dates, hold their hand again as much as possible. Again, an example of resources that we bear that we don't get reimbursed for, but we think it's important to make sure people don't lose coverage. And so far, I think we've been fairly successful, but not without a lot of effort.
Yeah, very similar in the sense that we've been using our technological aspects to send out my chart blast to say you may be coming up on recertification. How can we help you with this? More often though, it's our phone calls. So we do so many outreach phone calls to our patients about their care gaps, what they need done. And so it's tacked on to almost every single conversation in that sense. And then when the patients come in, I think when they hear it from our front desk, from our doctors, I think that that's going to be the most critical point, because that's when we can probably give them the most resources.
And staying on this theme of technology, I know one of the big changes for primary care during COVID was around telehealth. And so I'd love for you all to share your experiences using telehealth. And we can start with you, Stephanie.
As much as I talk about technological stuff, a good 50% of my patients are above 65 and do not use any telehealth aspect whatsoever. It's more in that kind of 30s to 40s or very early 20s that you might get this. And I think it's a great use for those groups of people because they're at work. They don't have to take the whole day off. They will shoot me a text message and say, hey doc, can I just get my refills? Or there's this one little lesion, can you take a look at it? And they'll send me a picture, right? So it has made so many things easier, but there's still a lot of effort and uptake for getting people to like something new. And so I will say that overall, most of it is my patients will come in and see me. They are so happy to come in and see me. And they'll even just stop by and say, hey doc, can you take a look at this? I'm like, in the middle of the waiting room?
I would say the same. In our center, I think the older population, it's less acceptable. but not completely unacceptable. But working with a lot of younger people, especially with my adolescents and young adults, they love it. And for us, it's also easier because they usually show up to the appointment, the telehealth appointments, because it's convenient for them. And we're talking about being patient-centered. That is patient-centered. I'm not happy about the different reimbursement rates that have come up where our workforce has to be in the building to do that. That poses a lot of issues in terms, I don't know if we want to get into our workforce right now, but we love the option. Our community did struggle early on, but it was mainly due to structural inequities in the community in terms of Wi-Fi connections and broadband. And our kids struggled a lot in terms of logging in for their schoolwork, but also in terms of having their telehealth visits, because early on we used that a lot to reach out to our families. And so again, what we're doing is working with the community to advocate Wi-Fi should be free for all. And then, so we've been developing a coalition in our community to do that, to lobby for these resources. But just imagine if we were getting paid at a high rate, we could help our families more to do that.
And pick up what Paulo said. So first of all, COVID fast-tracked telehealth, right? Telehealth has been around. It was very limited in terms of use. It was very restricted in terms of how it was done, in terms of where the patient had to be, where the provider had to be, all those things. COVID really fast-tracked it. And again, it's a modality of delivering care that now is part of what we do every single day and needs to be allowed. And so payment parity is really, really important right now. And I know that the Assembly passed a bill around payment parity so that the provider and or the patient don't have to be in the health center for that. Otherwise, we get a very decreased reimbursement rate. So if my patient's at home and I'm at home working, because the other thing that I think COVID did was talk about life balances, right? People are now very comfortable working remotely and doing it very, very well. And so you can actually render care, particularly in behavioral health fields, but even in some other fields, you can render care very effectively through telehealth for those who have adopted it. But now the requirement is such that either the patient or the provider have to be at the health center in order to get the full reimbursement rate for that. And that's just not fair, right? We can't be going backwards. Now that horse is out the barn, we can't try to corral and bring it back in. So that payment parity issue is very, very important to us to make sure that we're able to still do this for those patients who want to still engage with us in that sort of telehealth process and those visits that are conducive, right? I can't give immunizations through telehealth, right? So you got to bring them into the health center. But behavioral health services, dermatology services, some of these other things, follow-up care, for a visit, from an ED visit, a lot of that stuff can be through telehealth. But if we're not going to get reimbursed at the right rates, it's going to be very limited for us to be able to utilize a technology that's in front of us now. And Wi-Fi is a big issue. I agree with that. Everyone should be entitled to Wi-Fi. It should be a right for everyone in order to communicate.
Great, and I do want to go to the workforce issue, but if you want to say something else.
No, I was just going to piggyback on what you said. It really is an equity issue. Why is it always we have restrictions for Medicaid patients? Why can't we, the commercial insurance are paying everything. Why can't we do that? It's a choice that is made, and a different choice can be made. So that's what, if we want equity, the right choices need to be made. So workforce.
Thank you. Also an equity issue, but we'll start with Adam, because I know you've done a lot of work around trying to improve the diversity and create opportunities to make a more diverse healthcare workforce. So I'd like you to talk about that.
So two ways. First of all, I think that one immediate challenge, right? We do have healthcare workforce shortage. We know that, and in different areas. And now that we're expanding that care team, we have to be mindful of other things besides just the MD. But in terms of the pipeline, I've done a lot of work on, just trying to get more Black and brown people to become doctors. Bottom line, right? And this is something that has been a very challenge and something we work on over and over again. And how do we get these young people motivated? Dr. Collymore talked about this earlier. The expense of medical school is incredible now. To think about a $200-something-thousand debt when you come out of medical school, that's a mortgage, right? For many folks. So how do we make it easier for these folks? So that's a discouragement there. And then the lack of mentorship and guidance along the way to get a workforce that's dedicated to working in these communities. And then once they do there, how do we avoid them going into, as Dr. Collymore said, into plastic surgery, because that's much more lucrative. Pediatricians, we don't get paid a lot. That's not true. We get paid decently, but definitely more than I ever thought I would make. But still, when you have these high debt burdens, it's not going to attract them. And then when you add further to recruiting them into places like ours, FQHCs that don't have the same benefits and sort of salary structures that some of these academic health centers have, but we're at the front line. And so how do we attract people to work in our health centers? And I'm very passionate about the work that I do, and I tell people, if you really want to feel the work that you do, you come to FQHC because it's tangible work. Sometimes you do things and you don't know the ripple effects that it has. You don't know the feeling, but we take care of someone, the next day we know the effect that it had. Right? And so it's very gratifying in that sense, but that's not enough when you have these high debt burdens. And so we have to really think about how do we cultivate a new generation of providers by focusing on the primary preventive care services, compensating those providers more, and then making sure that those kids, like the little Adam Apontes running around East Harlem now, who have this daring dream to become a physician, get the guidance and support that they need to get there, because they have the capability, but they just don't know how to go down that path. And so, I'm very proud of a non-for-profit, shameless plug, Mentoring in Medicine, that I chair. I'm the board chair of that organization, and for 15 years we've been working with students just like I described to help them get in and navigate the healthcare field. And I'm proud to say that over 15 years we put 521 students into medical school and touched 62,000 lives. We need more of that work. We need more of that work. And so, how does that factor into the whole Medicaid redesign? I'm not sure, but it's certainly something that is another problem that is going to impact our ability to serve these populations, because these are the individuals that are more likely to work in these underserved communities.
And Stephanie, I know you were inspiring young people just this morning. So I'd like you to talk a little bit about that, but also just some thoughts about other care teams.
Actually, I was going to talk about loan forgiveness, but okay.
You can talk about loan forgiveness too. It's also proposed in the waiver, so it all ties together.
I was really pleased to see that the loan forgiveness was part of the waiver, because I actually got loan forgiveness through original Obamacare. So I was a National Health Service Corps scholar, or whatever you call it. And I was able to pay off all of my loans. It made it so much easier for me to go into primary care, because I wanted to primary care. We all think about the price tag, and we think about well, what is this gonna look like for the next 20, 30 years while I pay off a mortgage, essentially? My education, is it enough, right? And some of my students today were asking me, how do you see yourself through this? In the worst moments, did you ever doubt this was the right choice? And the answer is no. I never doubt that choice, because I felt called to come into medicine and to help out communities and families. And I was given loan forgiveness, and I was and this makes it even easier for me to do that. From a workforce standpoint, I think all of us are struggling right now with recruitment and keeping our people, because they're asked to do so much right now. And we're not even able to kind of give them the payments that they need, because we're stuck, whether it be unions or what have you, at certain prices, right? And in order to do this work, we need bigger and bigger teams. We need social workers, we need case managers, we need a pharmacist, we need a nutritionist, we need a behavioral specialist. And so, and I have built teams like this, and we feel like we're doing good quality care, but everyone's gonna look at that price tag at the end of it. With respect to diversity, I'm actually quite proud to be part of my practice, because we have people from all walks of life. We have 2 brown docs. We have a practice manager who's Black. We have 2 Asian docs, okay, myself included. And all of our staff speak Spanish, they speak other languages, and so we're pretty diverse in that sense. And I've done a lot of work to kind of mentor other physicians, whether they be females, women, or people of color, because, you know, I'm an immigrant child too. And if it wasn't for somebody else to open the doors for me, how else was I able to, you know, get to medical school that I went to, or even be the certain roles that I've done, right? And so I've been doing a lot of mentoring as well, you know, with men and women of color, because honestly, that's how they know that they can. So getting to the story this morning, so I was talking to these high school students and college students who were doing a summer internship, and they asked, what led you to go into medicine? And I talked about how population health is an opportunity to do health policy, to improve quality, to improve communities. And I hadn't thought about that when I was in med school. In fact, you know, at that time, the big P, population health, was like the 20,000-foot view. And I really wanted to do the 2-foot view, meaning be face-to-face with patients. And this kid, he was a sophomore at Johns Hopkins. He's one of our volunteers. And he's like, explosions happened in his head, because he's like, that's what I've been wanting to do. And suddenly he was like, and the doors have now been opened. And I was like, I'm so happy to hear that. Because, you know, he said he wanted to be a physician and he just couldn't reconcile it. And I was like, well, come into population health. I did not mention this, but, you know, he's a person of color. And I was like, I am even more happy that you want to do this. Because I was like, we need more people like you.
No, I think just from where we see it as an integral to taking care of communities, and so that these communities can trust us. But we need to be a little bit more proactive in sort of helping the community realize that it's possible. I mean, growing up, I used to take my grandmother to translate. I never saw a doctor that looked like me, and I didn't think I could do it. It wasn't until, years and years with great mentorship that I was able to. But we need to be a little bit more proactive in developing programs for the community, and not just in, the medical profession, all of the allied health professions, because it really does take a team to do the work that we do.
That's great. One last question, and then we'll transition to Q&A. And I want to start with you, Stephanie, just thinking about how we've touched on it throughout the day, but thinking about people who have complex health needs and how you help them navigate with your care team and through all of these different systems, and just speak to your experience about that and potential opportunities to improve those.
Oh, that's in itself is a very complex question. Part of this is I'm an early innovator, and I feel very comfortable, working with all different staff lines. I actually enjoy developing staff lines, and so in that sense, like raising up our pharmacists to be comfortable to do co-management, raising up our nutritionists to feel comfortable talking about weight management and diabetes in high-risk patients. But I think one of the biggest challenges is medical schools don't train doctors to be comfortable with this. Like, you would think that it's so easy because we are the heads of, resident teams and medical students and all of that. But when we come out of medical school, we want to see the patients ourselves. And we feel that it's gratifying for us, it's fulfilling for us. But there's no good way for me to replicate myself other than teach other students and all of that, right? We should be able to utilize teams so much better, because there are things that I, as the physician, is not absolutely necessary to do. And some of those things are like, team-based care. We talk about like preventive health. So I have patient care liaisons who call. My medical assistants ask at every single visit. By the time they get to me, usually it's already pended, which is amazing, right? Because then I'm like, okay, let's focus on what you really need to talk about today, right? And so building teams like that, it takes time, it takes innovation, it takes money, and it takes willingness to change. And so part of this is sort of like an ask. I don't know if there are anybody who are in medical education here, but there are schools out there, I think Hofstra is one of them, that are moving in that direction where they're like, you are the executive overseeing these teams of people, and how do you manage that? Because we want to do our best for patients.
I see our clock going, so I'm not sure if we're good, but I'll just say, medicine is a team sport, right? So we need everyone working at the top of their licenses and really allowing them to do the work that they do so that we can focus on those things that we do best in terms of providing actual clinical care. Some of the other stuff that we do to prep that patient before they get in the office, a lot of the team can help us with. And so we want to make sure that those individuals have the knowledge and skill sets to achieve it, the education and understanding of why it's important.
Great, thank you all for such an engaging discussion. We'll continue into our Q&A. For our in-person audience, we would again encourage you to scan the QR code to fill out a session evaluation right after. We can invite anyone that wants to come and ask some questions to the mics in the aisles. I can start with a Zoom question. How can you include referrals if you include the performance of securing timely specialty clinical services, or referred to as the referral process? Are you still able to provide quality? Sorry. Okay, we'll come back to that one. With the expanding responsibilities related to serving social and behavioral health needs in primary care, how has your practice addressed those needs? And possibly what partnerships have you developed with other organizations such as managed care organizations, community-based organizations, specialty care to support that?
Yeah, I think it's all above, right? Because I mentioned earlier, we can't do it all. So we are very intentional in trying to find partners. Our food pantry, for example, that we established was through a partnership with the MCO and a food pantry in East Harlem that provided us the foods. A lot of the activities that we do, we look for help. And we look for partnerships, and it's a reciprocal sort of relationship as well, because we also offer them services that they don't have in place. So there may be a community-based organization that focuses on, helping domestic violence victims, right? We don't have those resources. We have a direct referral to them, but those women or people who are exposed to domestic violence, they need health care, and they'll refer back to us. And so we do a lot of work in our communities to really sort of build those networks and those linkages to help us all collectively do our work, because individually we're not able to do so. And we've done a very good job. I mean, we've been around for 50 years, so we have quite a few linkages that we've developed that help us in those things. But there's always new partners that we're seeking.
Yeah, I think just being proactive, really engaging communities, not we're here, come to us, but actually engaging and seeing what their needs are and how we can support. I'm very lucky to work at a center that has an amazing family support department that helps with all of these amazing relationship and resources for our family. But a lot of communities, those things do not exist. So that's why reform is going to help.
Maybe I misunderstood the question, but for the things that we are able to build, we build, right? Integrated behavioral health. A lot of us do collaborative care and things like that. In order to make sure that we are getting patients in, though, right? Access is a huge issue. Doesn't matter who you are, doesn't matter who you talk to. But psychiatry is one of the hardest to get patients in these days. Even at our own health system, who have psychiatrists and things like that. So what did we do? We actually built facilitation methods with our social workers, and we are following connectivity rates, and we are holding our partners in behavioral health in the community accountable to what they promised. Can we get these patients in sooner? How do we get them the care that they need within the 2 weeks as opposed to the 4 to 6 weeks? In the same way, there are things that we are not good at, and so we have to partner with other groups in the community, like food pantries, God's Love We Deliver is one of our community-based organizations, things like that. And so we build organically. I think that's what most of us have done, build organically and then curate those relationships when they really work.
Thanks. Hi, Rebecca Antarnovic. I'm the director of the Health Law Unit at the Legal Aid Society. Thank you for this panel and for all the work you do. You've touched a lot on just the difficulty of making time for all the things that you need to do that you aren't paid to do. And I was interested to hear a little more about what you do about just dealing with denials. Most of our clients are on Medicaid. We deal with denials by Medicaid managed care plans all the time, and see for our clients how stressful and time-consuming it is to fight these denials of things that clearly should be covered, and not to mention the barriers for a lot of people of even getting the assistance from their providers that they need to fight these denials, and and sometimes even just helping our clients to feel empowered that they can actually ask their doctor for this. I'm sure your patients are, sort of a few steps ahead of a lot of the individuals that we work with, but I'm just interested to hear more about kind of how you integrate this into your practice.
I mean, as someone who works a lot with young adults, this is one of the most frustrating things. I gave you two conditions, acne and abnormal dentition. Two of the areas where acne medications for Medicaid patients is not covered at the same way, and it's a lot of, we talk about administrative burden on us, and so it's, luckily now it's online, you don't have to wait on the phone, but going online, putting in just justification just for an acne medicine. I can't tell you how, a lot of my patients, especially young adults, need braces. To cover, it's almost impossible. First time, it's always denied, and trying to get it covered multiple times, writing letters to get this done. My team doesn't smile. We talk about behavioral health, preventive behavioral health all the time. Young adults, appearance matters. So why do, children in Medicaid can't get access to those things? So it is one of the most frustrating things. And so you end up doing more, taking your time to write those letters, calling, justifying, trying to do that. But a lot of times you're still unsuccessful. It's very frustrating.
I think one thing you have to remember that while we like to think that MCOs run Medicaid, New York State Department of Health runs Medicaid. All the MCOs who are Medicaid providers, and I guess my MCO partners here may give me a little hand clap a little bit because I'm defending them to a certain degree, because they all have the same regulations by New York State Department of Health in terms of what they deliver as far as what they allow to pay for, and they just had slightly different window dressings. Now the formulary has changed because they all had different formularies. Now there's one formulary for the state, so that makes it a little easier. But the real pushback is really in terms of, what is New York State DOH allowing us to do, right? And sort of creating a process for it. And I'm also going to blame us a little bit as providers, because oftentimes we don't take the right steps to get to where we need to get to in terms of what medication. We can't go from, you can't have a shotgun effect on certain things, right? If a patient needs amoxicillin, why are we giving them, Augmentin or whatever it is, a medication that's not necessary? So we have to be mindful of that a little bit, but we don't want unnecessary barriers for essential care, and that's the part that, we get frustrated on. And then communication between our payer and the provider, which I worked at United Healthcare, so I can say this as well. There was a lack of communication between the MCO and the provider. Say, hey, Dr. Pina, if you need that acne medication, before we can allow that, we need you to see the patient use this one first. And if you show me that he tried that and failed, then I can authorize that. And that communication doesn't happen. It's just a denial with no reason for it. And I think that level of communication has to be put in place so that we all have a partnership in this. And because, there is a lot of waste in healthcare as well, right? So we have to be really mindful of that.
Yeah, 100% agree. So often it's the patient who tells me, hey, doc, that medication that you sent isn't approved. I'm like, you were on this like 5 minutes ago. Well, what happened? I think it was the formulary change, actually. That's what happened. Yeah, all the time. So for us, it's figuring out who on the team is the best person who can address this as quickly as possible, because it's not always the doctor, right? I have nurses who are amazing at being able to get medications approved. Often radiology calls me and says, hey doc, this is gonna need a peer-to-peer, and of course, I'm like facepalm, I'm like, oh no. But in those cases, it makes sense, right? But referral specialists send over all the paperwork and everything to kind of get something approved, right? So finding the right person on your team and distributing the pain overall is probably the best way to go about it.
I just wanted to add as well, just reiterate, and I keep going back to it over and over again, this is a systems issue, and if the system is creating inequities, okay? There cannot be a two-tier system for kids on Medicaid, which are mostly brown and Black kids, to get less for just because they are Medicaid. It's a system that's creating, it's not blaming. I am part of this system. I'm part of the issue. So, but we all need, DOH, state DOH, MCOs, no one specifically to blame, but this system was created. It's created to propagate these inequities, and we just need to move away from that and stop.
Thank you. I'll invite Emily to introduce.
Can I just ask a question?
Sorry, yes.
So to that point, I really appreciate the system level conversation and the inspiration for kids of color to become doctors, to get into healthcare field. What is your opinion on the Supreme Court ruling against affirmative action that's going to hold us back now? And we won't have our brown and Black and Indigenous doctors and nurses.
Yeah. No, I mean, that's a whole new conference all day, quite frankly. We could talk about that all day. I mean, this is a lot of work that I did when I was in academia. I was a dean for diversity at a medical school, and we worked a lot on these issues in terms of making sure that, I think what people don't understand about affirmative action and some of the measures that, the Supreme Court shut down is that affirmative action is not lowering a bar. No. It's allowing an opportunity. It's opening a door. We're not lowering standards to let people who come in. You can't be a doctor as a D student. You just won't pass medical student school. It's not going to happen, right? You have to have a certain intellect. But I need the opportunity to actually get to medical school, to apply to medical school, to be considered for medical school. And diversity, is a business imperative. Diversity is going to really drive everything we do. Now you're getting me on a whole soapbox now because, when you talk about, think about your financial portfolio, folks, right? What is your financial advisor tell you the first thing to do? Diversify your portfolio, right? And so we know that diversity is going to create innovation. It's going to help us to solve cure diseases. You think about how we did research in this country for so many years, and no offense, but we had white men doing research on white men, coming up with a solution for hypertension. You got this pill, and now you're giving it to a Korean woman. Think about that. Doesn't that sound ridiculous? Right? And so if we don't have that diversity in the healthcare workforce, then we're not going to be able to have broadly applicable solutions and cures for the disease we see. So this is a real big insult on us in terms of academia and diversity within the healthcare workforce. But there are ways to work around it. And there's a lot of folks that I know at the AAMC that are working really, really hard to make sure that schools that are committed to diversity and want a diverse healthcare class, they could just do it. There's nothing, just open the doors, start accepting people, be more holistic. Think about, I went to medical school, I was working 35 hours a week during school, paying for my own bills. Imagine if I was able to spend 35 hours studying, or maybe 30, because I would have hung out a little bit, right? But I would have been able to spend that time on my studies. And so if I did that well, considering that I had to support myself, what happens if you put me in a supportive environment in medical school and allow me just to focus on my medical education, how well a student? That's what we call holistic review. And we need more holistic review across the board in terms of academia. And I apologize, but that is just something that really
I'm very
really
concerned
offended.
about this, right?
Yeah, absolutely.
I think
Rightly
we got
so.
to a point where we are talking about structural racism. Like, we weren't talking about structural racism for the longest time. Now we're talking about it, and now we get slapped in the face with this.
Thank you for that question. Yeah, but I think we're also all in areas where we are at the table making decisions. So we just need to continue to fight. That's it.
Thank you so much again to Alex, Dr. Aponte, Dr. Wang, and Dr. Pina.
All right, everyone, we are at our last session, and I have the pleasure of introducing our secondary keynote speaker, Kathleen Noonan. Kathleen is the president and CEO of the Camden Coalition, which is a multidisciplinary community-based nonprofit that works to improve care for people with complex health and social needs based in New Jersey. So really drawing together a lot of the themes we've talked about today. And with that, Kathleen, thank you.
Thank you. And I just want to make sure you're going to pull up my deck. And there we go. Okay. Hi, everyone. Thank you so much for having me here. It is great to be here. I'll say that I started in New York City at Citizens Committee for Children in 1990 when we talked about border babies, and I now actually regret every joke I made about New Jersey while I lived in New York City. I really do. I just want to say that. I want to get that off my chest to start. So anyway, I am going to talk to you today about, make sure my clicker's working. There you go. A lot of what we've learned through trial and error. I want to make sure that all of you leave here today thinking that there is nothing that I talked about that is Camden Coalition exceptionalism, right? There's nothing that I'm going to talk about that is because we are more special or more passionate or have more resources than anyone, right? It is because when we've had successes, we've actually, through trial and error, figured out something and gotten it right. And when we've had failures, we've gotten it wrong and we've been honest about it, right? So that's all it is. And that is because sometimes people say, well, do we need to create a Camden Coalition? No, you don't. You have all of the Camden Coalitions or, the health centers that could do what I'm talking about here today. So I am not here to propose that. And I just want to get that right out there. Some of what we've learned, which I'll share with you today, is that short-term care management alone is not going to remedy lifetimes of complexity and embedded inequities. It's just not. We thought it might be able to early on, but we know that it can't. The second thing that I'm going to talk about is, and this is the jargon alert warning in the talk, but about an ecosystem, a word we all use, and we all use words teaming and collaboration, but unless we really, really figure out how to do it in a very different way, the panel before us talked about Hofstra teaching their doctors in a different way, we are not going to get this right because we are bumping into each other and we need like infinity edge pools and we've just got like just deep abysses. And then one of the things that we've learned is that we can't just focus on individual level metrics. We actually have to force ourselves to think about, like, what does it mean to team? And are we teaming? And are we working with people that can say we're teaming and we're doing a bad job of it, or we're teaming and we're doing a good job of it? So that's basically what I'm going to talk about. So we started in Camden City, focused on people who accounted for a disproportionate amount of healthcare. And for those of you who might know us from 10, 15 years ago, we called this hotspotting, right? And this was the idea of this breakfast group. And when you think about this breakfast group, think about physicians, social workers, nurses, a woman who runs our needle exchange in Camden, who was doing community health worker work before
anybody in Camden sat together and said, we're not doing a damn bit of good, right? I mean, we keep our clients keep cycling in and out, and we're not helping them at all. And we need something different. And so being very interested in data, and Jeff Brenner started the Camden Coalition with lots of amazing visionary ideas. We said, what if we figured out a way to identify the people who are in that 1% of patients that make up 30% of the receipts, and we actually meet them where they are, and we think about their needs more holistically. So that was the idea of it. So our model in the beginning, and still really our model today, is up there for you, right? It's bedside engagement. We don't always do bedside engagement now because we do other sorts of types of engagement, but bedside engagement, and right there it was actually talking to people, most of them Medicaid members, who were in the hospital and seeing if they wanted to enroll in a new care management program. And then it was a new care management program because it was a nurse, a social worker, and a community health worker who were gonna go out then and meet you in the community. And you can see some of our care team members in community visits. I can tell you that a lot of our community visits happen in shelters, at the McDonald's, you know, if that's a community visit, often if I see that right now and I see a picture of that, I think, oh, we housed somebody, because it just wouldn't look like that. We measure, at least early in our model, we were very focused on readmissions, return on investment, remember, was talked about so much. But we were also really focused on connection to care, right? Is this 1% connected to primary care in a stable way? Do they have a specialty care provider that they see regularly? And then we were also addressing we called health and social needs, and now we call them complex health and social needs. But this is an early patient of ours, Michael. I did not know him, but I still have care team members who did. And in the beginning, we actually took 16 cards that looked like Monopoly property cards, and we would just place them down in front of people and say, we just want you to take a look at them, like a sort of Rorschach, right, almost? Although I don't think we use that word. But anyway, but, you know, and just pick up the ones that are the most important to you, right? The cards. And they had words maybe on one side, pictures on the other. And this young man, actually, I now probably can't read from that far. This is where I need glasses and glasses. But on his list of needs that he wrote out himself, he has his birth certificate and his driver's license and a non-New Jersey ID. And he needed housing and schooling. I mean, this is someone who was identified by us because he'd been into the emergency room at least 2 times in a few months. He'd been admitted at least a couple of times in a few months. He had other needs, and 6th or 7th on his list is substance abuse treatment, right? So this is what was most important to him at the time. So that was our care model. We wanted, at the time, to address the fragmentation that we saw. And sorry, I just want to make sure I think that my slides have just gone out of order. I am so sorry. Oh, I know what's happening. It's the video. There you go. Okay, I have a video, but my video slide is no longer here.
I was tired, and I turned myself.
There we go.
And I had medical issues. I couldn't eat. I was doing so much heroin that my esophagus had closed up and I couldn't eat. For almost a year, they was feeding me oatmeal and applesauce. Remember carnation milks and stuff like that? It was a struggle in the county. Just you telling me that the coalition was there and that you had legal partnership, you know, like with the justice system, it gave me hope. It gave me hope, and that day, you know, we prepared. You showed up to court with the lawyer from Coalition, actually 2 or 3 times.
Yeah,
and you guys were there all day, and it meant something to me. You gave me a phone. I don't know if you remember, you gave me a phone.
Yeah.
And actually, the phone that the Coalition gave me saved my life. I was at the shelter. Like the 3rd night, I caught a pneumonia. I went to the emergency. They gave me some antibiotics. The next day, my leg swelled up. all my fluids were going down to my legs, and they said it was some type of infection, so they gave me antibiotics. The third day coming out of the shelter, it was about 7 in the morning. I couldn't breathe. I thought I couldn't get no air into my lungs, and if it wasn't for the phone dialing 911, I wouldn't be here today talking to you. So I'm very grateful with that little phone you gave me.
I know, that little flip phone.
The little flip phone. And I remember I fell out on Kane Avenue in Broadway. And all I remember was waking up in the hospital. How did you get the news?
Basically, it's like a little alert, like any clients that are on my panel, I know if they're in the hospital, like ED visits, admissions, that's how I knew.
Okay. Now, when you guys came to see me at the hospital and they made the decision to send me to the nursing home facility, that's when it all began. That's when the coalition was more in play, where they became so, like they had such an impact in my recovery, as well as my life in general, where I started seeing hope. They were there. At first, I couldn't embrace it because I said, what's the catch to it? But I felt the genuine love from everybody, not only from you, from Janae, everybody that came to visit me from the coalition had me open up a little bit more. And it was a struggle when I was in there. I wanted to leave so many times, Brian. I wanted to use a couple of times. I was frustrated because I was diagnosed with one thing, then another thing. It started from emphysema to congestive heart failure to COPD, then to cancer. At one time they said I had AIDS, and I struggled with that. And then 2 weeks later they said it was a computer error. I wanted to use real bad, and you're the one that kept me, from using. Just the support that the coalition was giving me. It was giving me hope. It was giving me strength. It was giving me power. I started feeling alive inside.
So that was Charlie, and I'll now do the intro to my video, so you have some context. Charlie, we met Charlie in the Camden jail. And the context that I especially want you to know is that Brian, the community health worker, actually didn't know when he first met when he first met Charlie, that he was someone he knew. Charlie used to run a halfway house in Camden. And about 5 to 7 years earlier, Brian was in very active addiction, and he was unhoused. And he was looking for a place to live. And Charlie, and we didn't have time to go into the whole video, but Charlie talks to Brian about how difficult he was, that he wasn't an easy guy, but he took a chance on him and let him live in his halfway house. And then 5 or 6 years later, Charlie relapsed, found himself in jail, and now Brian comes in as a community health worker. Brian is actually still at the coalition, is now our housing coordinator, so he is wonderful. But we have a lot of Charlies at the Camden Coalition, and you have heard today by half a dozen or more of people who are treating people like Charlie, just like we are, and it takes a lot of work. So, one of the things that you learn from working with people like Charlie, from dealing with these systems, is that it's the fragmentation, in and outside of our systems that are just contributing to these incredibly poor outcomes. And that is certainly one of our theories of change about, what are we going to do about this problem? And even today, when you hear about the 1115 waiver, I sometimes just think it's just more fragmentation, right? So what are we going to do about that? So as we were sort of grappling with our theory of change and fragmentation and working on our care model, we had the opportunity actually to be part of a research study. And that research study was with J-PAL, MIT, and I don't know if any of you saw the op-ed that was in the Times the other day by Amy Finkelstein. She's our primary researcher, but we had the opportunity to actually test out our care model with them and to test out this 90-day model. And if you asked me, off the record, I'm just kidding, I know I'm on the record. If you asked me off the record whether we were ready for an RCT, I would say sort of. And if you asked me off the record whether we measured everything that we should, I'd say no, because we were really we really had to stay to administrative data that was already collected. That's how MIT does their models. And so there was no qualitative data, no new measures, just measures that were being collected by administrative systems. But we did it, and I love the spirit of why we did it. We did it because this field is under-researched, right? Because health services for this complex population is really hard to do, and we thought something to continue the discussion is the right thing to do. So we did the RCT, we enrolled, I'm sorry, let me just go back for a second. So we did the RCT, and the actual research question was at 180 days after a hospital discharge, do patients enrolled in the Camden Core Model experience a lower rate of hospital readmissions? So our very heady answer to the research question is no. Lifetimes of complexity and embedded inequities can't be remedied by short-term care management. We need broader ecosystem change and multifaceted measures of success. Now, what did the study show? The study showed that when you looked at the control group and the intervention group at 180 days after hospital enrollment, there was no difference in readmission rate. The study did show that there was a statistical difference between the intervention group and the control group around SNAP benefits, but that didn't get picked up in a lot of press, although we were very happy about that because that's one of the things that we did, and it sort of fit our SDOH model. Other thing is we have actually been working on another study with JPAL and also doing secondary analyses ourselves, and we just published a week ago in the Journal of Managed Care a secondary study that looked at those people who got higher dosage from us. And if you compare the people who got higher dosage of care management from us versus those that didn't, we do show a statistically significant difference of readmissions at 30 and 90 days. Now, of course, lots of questions around why some people got higher dosage from us and some didn't, but it does show us that when we engage, we could actually meet some of those metrics trailed off at 180 days, right? So again, that short-term care management is just not significant enough, at least from our experience, that you can really change things in that short of an intervention. So as we reflected on the results, we asked our community advisory committee, and these are people like Charlie and Michael that we've talked to, and other participants in our programs, and then a bunch of just people who are lifers in Camden, who really care about the city. One of them, a former social worker in our big hospital there, Cooper, another former teacher. They come together, they have different values, they often get into arguments. It's very interesting, but we brought the results to them, and kudos to everybody who's been saying that these communities are really we just underestimate them because we bring research studies right to them. I mean, we say, this is the study in New England Journal of Medicine, here it is for you to read, and we're gonna walk through the study results. And these are the word-for-word reactions of some of our community advisory members. They said, we were obviously asking the wrong question, we need to ask better questions, think you measure how much people are involved with their community or their family, where do we go from here? Because they said it's not making a difference, but it's making a difference to us. And then finally, nothing works overnight. Everything is a process. Building people up who have mental health issues, and spiritual issues is a process. And so we were very inspired by their reaction to this. They were not let down the way we were. They were just like, what did you think? There was going to be a silver bullet? They were almost having to teach us, what did you really think? We have to keep working on this. We have to get better measures. We have to think about longer term engagement with people. So we had realized along the way that, short-term care management wasn't enough, and we had done other things. I don't want to make us sound more Pollyanna than I'm making us sound. And we started to build pieces that we saw weren't there. We started care management meetings in 2007 with all of our hospital partners. They were not as big in the beginning as they are now because, to Stephanie's point, there are a lot of care managers now, right? There are a lot of navigators now. But in the beginning, it was just anybody in Camden, people from our FQHCs, from housing shelters who were doing any kind of care management. In 2010, we created a health information exchange. We did a 7-day pledge in 2014 that actually had every primary care office in Camden agree that they would get any Medicaid patient into their office within 7 days. We did show a statistical difference on that study, but only for the less complex. It was the less complex patients that drove that. And then finally, we started a housing program in 2015. So we have been building some of the pieces along with looking at those individual metrics, but we hadn't quite put it all together yet. So we were thinking, as I know all of you are, we're not the first people to think about an ecosystem, but for us, we started more and more to think about this local network of organizations, sectors, and fields that are working collectively to address the root causes of poor health among individuals with complex health and social needs. We launched a national center in 2016 to bring together people like us that were thinking about this, and charged with the marching orders from our CAC, we really forced ourselves to think more about that bigger system piece in addition to the individual metrics. And so a couple of years ago, we actually created a new organizational goal for ourselves, which was by 2025 to confront inequities and system failures by strengthening ecosystems in 500 communities in Camden, across New Jersey, and around the country. And I don't know if anyone has heard that word BHAG. Has anyone heard that? You've gone to business school if you had. It's called Big, Hairy, Audacious Goal. Well, that's what we were trying to get at, but we really dislike that word. In fact, I am quite sure that if I was with my mother and I said BHAG, she would think I just said something that I wasn't allowed to say. So we call it our BFG, our Big Friendly Goal. And everyone around the coalition calls it the BFG. They're like, how are you doing on the BFG? And I've checked copyright law, and I think we're okay with the doll estate. But needless to say, we are thinking now not just about those individual metrics, but also how are we doing in the ecosystem? And we knew that we couldn't just come out to audiences and say, we strengthened 100 communities, but we actually had to have a way to show you how we strengthened 500 communities. And so we did this just for ourselves. I just want to say that. We actually spent a very long time coming up with the 6 domains that we think we have to influence to get to the patient metric at the end, the client metric on the end. And each of these domains has subdomains or attributes. And we actually, because we like data and people, actually took each of these subdomains and actually defined what it meant to do teaming and collaboration at a limited practice, and what does it mean at an advanced practice. And we've done the same thing for each one of those domains. Services, data, I could go on, obviously. But the point was for us to be able to, at the beginning of any kind of work we were doing, to say, hey, we really want to work on this metric, this individual level metric. Which ones of these attributes are the most important for us to actually be able to get to that individual metric? And I'll give you, hold on one second. Okay. I am just having slide deck trouble today. because I had a couple of examples in there that were taken out. So I'll just tell you about them, or maybe I forgot to send them. So a couple of examples. So we have a project going on in Camden right now, and I'll go back to the workforce slide. And the project in Camden involves, it actually involves the four or five counties, because now we work in all of South Jersey. But it involves prenatal care initiation rate, right? It's a Medicaid pay-for-performance program in Camden. And everyone, all of the hospitals, the FQs are actually left out of it a little bit. It's not fair. But are thinking about prenatal care initiation rate. Well, we, in talking to a lot of our partners, figured out that we were really missing emergency room data. And the fact that about 2,000 people a year were coming through 13 emergency rooms and were showing up as pregnant, or we were testing them as pregnant, and they did not have a connection to prenatal care at the moment they were in the emergency room. And so we said, what if we could create a workflow that actually matched them to an OB practice, whether in an FQ or a health system, that matched where they'd been a lot in their patient record. And then we created a sort of workflow for somebody to actually call them and reach out to them. And once you did that, could you also then get them connected to all the other New Jersey services that we have? And so we did that. We reached out to about 2,100 people over a year. And as it funneled down, 400 of them actually accepted care, which is really high for anybody that does telephonic work. But the really important thing to know is that that teaming and collaboration measure, everybody working on that actually rated themselves at the beginning of the project, right? So we had everyone say, like, you health system, and you emergency department, and you OB, like, where are you in teaming and collaboration, and where is that needed, right? And I can tell you that we've now done this with a lot of partners. Nobody rates themselves higher than now a 1.5. We used to only have 1, 2, 3, 4, but people spent so much time between 1 and 2 in their discussions that we decided, this is medicine, we don't have time for this. And so we put in half measures, and that makes everyone feel a lot better. And so we don't have any site anywhere that has rated themselves higher than a 1.5. But they actually talk about, where do we think we could get to in this engagement? So it's very interesting. Here we go, slides, here we go. We weren't expecting to do this, and just ignore the slide for a second, because it's like slide aphasia, and I'm talking off slide for a second. But anyway, we were not planning on on sort of bringing this out to the public. If you'd asked me a year ago, I would say this is our own internal tool that we're using. We want to make sure we have it for backup. But we found in so much of the work that we're doing that it's so helpful for teams, especially cross-system teams, or even 2 teams in the same health system, to work on. And we don't put the tool in front of them. It's very unwieldy, and it sort of makes you want to glaze over. But we'll take out a piece of it that we think is important based on what they've talked about, and then we sort of come up with a rating. And it's really just another part of our work, but we hope that it will help address that sort of individual metric piece and the ecosystem piece. So key takeaways in my last 30 seconds. Obviously, I've talked about that we don't think short-term care management for the most complex patients is sufficient. We think we have to create a lot more intelligence on teaming and collaboration. Our tool is one. There are other good tools that are out there. Health Begins has something like it, and I know that there are others. And to truly, truly move the needle, we really have to work simultaneously on individual level outcomes and ecosystem change metrics. So thank you so much. I meant to send a slide here that shamelessly plugged our conference. Is it okay if I do that? Just in case you are someone that works a lot in complex care and the intersection of health and social needs. We have a conference every year. We're having it this year in Boston. And I know I see friends from Unite Us and from Find Help and others who have come. And so anyway, hope to see you if it's something that you're interested in. And I think we move now to question and answers.
Thank you. Again, if folks have questions, feel free to come up to the mics, but we can start with some questions we got online, which I have in one of my tabs. So I guess one question, like thinking broadly about Medicaid, were there policy changes or investments that New Jersey Medicaid has made that have supported your work or things that you guys are thinking about at the Camden Coalition?
Yes. So actually, some of you, especially those of you who are in charge of budgets, are probably wondering, how does Camden get paid for this? I knew you were thinking that. Yeah. So, we actually are one of 4 nonprofits in New Jersey that's been deemed a regional health hub under legislation that we actually co-wrote with other nonprofits. And as a regional health hub, we actually work directly with the Medicaid agency and receive not an insignificant amount of money every year to actually run our HIE and make it available to really at this point, a lot of non-EPIC users. So the jail, housing shelters, that kind of thing. And then we also get funding for them to run our CAC and other things like that. So it's like, we're like an intermediary organization, and similarly to some of the intermediary organizations that New York has funded, and I think is thinking about funding more in the 1115. But in terms of the individual things we've worked on, usually now what we do is we try to tie something we're working on to something that is being incentivized by Medicaid in some way. And that just engages our health system partners more.
That's great. We have, speaking of healthcare partners, from someone at Health First, I think they say, reading verbatim, I think we all hope that there would be a favorable return on investment for the Camden Coalition initiatives. Do you think there will ever be feasibility considering the high costs of care to see that ROI?
I do see the ROI, but I don't think we're going to save money. I mean, I think that we might spend money differently. I can tell you that the Housing First program that I have, that Charlie's now a part of, Charlie is much less expensive than he was when we first met him. Right, so when we first met Charlie, he was in our program that was a nurse and a CHW pair with social work support. And we saw him probably every week. Now he's in a program with a CHW that sees him once a month. And if there's an acute problem, we might see him 3 times that month. But it's just much less acute all the time. And so I know, because we've done the math on people like Charlie, that, you know, it does save some money, but more, you know, but I think really we're just spending money differently, honestly, and better.
So as you've talked a lot about how you've worked with other communities, is that, and you've got the resources online, do you recommend other communities working with Camden Coalition, or are those resources really self-explanatory that someone could follow that guide themselves?
Yeah, I mean, we try to put a lot of information out that is so that people can just take it up and use it themselves. We've started to actually develop a set of sort of demonstration snapshots so that something like the prenatal care initiation program I just talked about, someone could read that snapshot and get a good sense of how they might want to do it themselves. So yeah, I mean, I was recently, I get hit up by venture fund people a lot. I don't know why, really, but they do call me. And a lot of the times it's actually because they want to have an affiliation for their doctors with the Camden Coalition. And some of it, I mean, we actually, it's not, they're not like all bad ideas or what have you, but I was talking to a venture person a couple of weeks ago, and he said, why aren't you for profit? I don't understand if you think you can really, giving someone like the story of Charlie, like, why can't you do that? And why don't you do that? And I said, because I get paid to give things away. And I also have a minimum salary of $52,000. And among other things, you can work for us 5 hours a week and get health care. So, I just have things like that make it like we would never be able to do that. So that's a long way of saying that people can work with us, and we do work with some states and teams and things like that, but we also get a lot of funding from people like our own state Medicaid office to really put stuff out there, and we're very lucky about that.
Hi, thank
Hi.
you so much for your presentation.
Yeah.
I'm wondering, did the Camden Coalition have any barriers to get hospitals to buy into your ecosystem?
Yeah.
How did you get hospitals to be more engaged?
We did through our health information exchange a long time ago. I have to say, because we built that before Care Everywhere in Epic, they were really bought in. But the other thing is that we really do share resources a lot. I mean, we got and so if we're applying for grants or doing anything like that, we really share funding. So the prenatal care initiation rate, the 6 OB sites that we worked with, we gave them each $10,000 for the year just to use for flexible funding. And so we try to do that a lot. We know like the leadership, but we also we know the med techs and the nurses and the docs. So I think that's how it helps.
Thank you.
Yeah.
And I think with that, thank you so much, Kathleen.
Yeah.
Another round of applause. Oh, is there another? Wait. Yes, please go ahead.
Okay. Yeah.
Just love your presentation and
thanks.
the pioneering work that you've been doing. You've been inspiring a lot of us for a long time. So I appreciate that. If you could spend a few minutes as you're working on the ecosystem, can you share some lessons learned on how you've been helping reduce duplication across roles and responsibilities?
Yeah, actually, I meant to have one slide that just said, it's about new job descriptions, damn it. So when let me, one anecdote, and then I will tell you how we do it. When I was at the Children's Hospital of Philadelphia, I started there. I started a center there called Policy Lab, but I spent with a lovely pediatrician named Dave Rubin. And then I spent my last 2.5 years in the C-suite working for the CEO. And one of the special projects I got was to figure out why a clinic that we had created, sorry I said clinic, Children's Health Center that we created, at the same site as a city health center, at the same site as a recreation center, at the same site as a library, wasn't having any, there wasn't any interaction between them. And like, the answer was very simple. Like, no one had it in their job description to actually work with anyone else. So we put everyone together in the same place, but there wasn't anyone at Children's Hospital of Philadelphia that suddenly had the responsibility to work with the rec center or that kind of thing. And so some of it is just really changing what people are going to do. And I could tell you with the prenatal care initiation program that I talked about, like at the end of the day, we were changing like people who were at the desk's responsibility to work lists. And that is not easy to do. And so, we try to bring people together and sometimes just have some like convening. It helps to actually show everybody numbers So everybody knew how many, so we sent out lists to 6 OB sites, but then we also said what percentage of calls sites were getting to. That's a little competitive, but it actually helps. And then we really work on sustainability. So as we were looking at that, we were also really studying the state's maternal health resources that they had available. And you know that there's another consortium that's actually already being paid to do this type of thing. So now the negotiation is that a lot of the health systems don't want to give it up to them. So that's our new negotiation that we're dealing with. But it's not easy, but it does take new job descriptions and sometimes people agreeing to do new things, something today that's different from what they did yesterday. Yeah. And it's really one of the hardest parts.
Yeah, I hear also, if I make a tie to something you said a little bit earlier about being able to spend money differently.
Yeah. And
that so there's new job descriptions and there's new ways of paying for those new job descriptions and really being innovative in our thinking to create a more collaborative ecosystem. So thank you.
Yeah, I think that that's true. And certainly when we hold meetings, we try to have a physician champion, a nurse champion, a med tech champion. I mean, we bring the whole team in. With I wasn't able to show you, but a mental health project we're working on in 4 emergency departments, we ask if the security guard can come in. I mean, we really, really try to think about, is everybody engaged in this?
Thank you.
Great. And so now, a final round of applause for Kathleen.
Thank you, Kathleen, for that terrific keynote and really putting a different spin on what we've been trying to talk about today in terms of collaborations and teams. So thank you for that. Before I give my closing reflections on the day, I want to take the opportunity to thank once again Unite Us for their sponsorship, covering all this amazing technical assistance and equipment required to provide a hybrid experience for those online able to participate for free. And I want to take the opportunity to have Dan Brillman from Unite Us come up and say a few words about Unite Us. Dan, there you are. Awesome. Please, some brief remarks so that folks can get a sense of your contributions today and what you hope to bring to the space. So
thank you so much. I appreciate it. Hey everyone, again, Dan Brillman, I'm the co-founder and CEO of Unite Us, a technology company that brings sectors together to improve people's health and well-being. I have to thank Kathleen, nice to see you, and I have to back New Jersey, I'm sorry, I'm a resident. But excited to be able to sponsor this and bring people virtually. It's great to bring people into a room together and virtually to talk about all of these issues, and it's been a very exciting day. I want to talk a lot about our values, what I'm hearing from everyone today, and it starts with, at Unite Us, we talk about our values of first is be a good human. Second is own it, like we got to own it together. The third one is always collaborate. And then the last one is think big. And so I think we're doing all of those things together today, which really excites me, and it resonates a lot of why we're here. But in the end, this stuff is super complex. And where do we start, right? And it requires obviously everything everyone has talked about today, and that's government, healthcare, social services, all working together, and it takes all of us, and we all have that drive, and I can feel it, which is great. But we have to have all the right systems in place. And so thanks to Kathleen, who just spoke, so I have to call her out a couple of times, but we know what we broke, and we know what we can do better, and we're here now, which is very different than where we were when I started this company with my partners 10 years ago. My co-founder, Army infantry officer, and myself, an Air Force pilot, still serving today. You know, we initially started with veterans with the same problem that exists today, but there were not conferences like this happening. It was a very different place. We were trying to get 35 organizations here in New York City to work together, to securely share information, to know what happens on the other side of a referral every single time, and to standardize that. It was a very, very different place, but now we're here. And so that's really exciting. and founding on the premise of that every organization really needs to be working together is really where we started. And it's all comes back to all of us, right? I want someone to help me through all of my points in life and all of the problems that I have by different agencies over time, even as a veteran when I get out of the military. And I don't want to tell my story over and over again. And patients don't want to tell their story over and over again. And I think we hear that all the time. A couple panels ago, we all just want this to be connected, everyone on the same page. And we know those problems are difficult. But we started here in 2013. This is our hometown. And 46 states later, and millions of people being served, and hundreds of thousands of organizations using our technology to communicate, to predict needs, to be able to be reimbursed for those services. That's just the start. And so imagine where we're going to be in 10 years. 15 years ago, iPhone. Imagine where we're going to be in 10 years. It's very, very possible. So I just want everyone to feel that. It's always been about the outcome. We talk a lot about activities and working together, but ultimately what it comes down to is that outcome. And so we need those tools to bring everyone together, specifically around our community-based organizations. They always have been delivering these services. They deserve the credit for what they're doing, and it takes all of us to do that, right? And systems, funding, and they've been doing it for decades. It's not new. It's just how we do it better every single day. And we need to share the load. And I heard 2 panels ago, we all need to be operating at the top of our license because we don't have time to do everything perfectly. We don't have the resources for that. So healthcare can focus on healthcare. Social care can focus on social care. Government can focus on government services. That's okay. But we all need to do it around the same person, me as the patient or the client, right? The people in need to do that. And so I just want to walk through a couple examples of things that I hope that happen. One, we need to start predicting these needs and getting proactive. And not just our healthcare needs. I think we're pretty familiar on when someone has chronic disease, they present those things and we're following up and trying to manage those chronic disease. But what about the combination of those things? And what are we doing about it? Should we wait for a healthcare provider to find out there's a housing need and then have to take the time to address that need? Or should we do it in a community-based setting where we can proactively get in front of that person using technology, using data to be able to get in front of that person and offer them those services? So we're ready to engage in a thoughtful and meaningful way because we have data in front of us to be able to do that effectively. Should we proactively start reaching out to people and asking them about the services that we are collectively predicting for them? We really want to know what's already going on with this client at all these different agencies. What if you could do that? And lastly, what if we can do that all from our systems like the EHR, because we're all connected in the community on technologies like Unite Us and integrated together. And lastly, imagine if a CBO is now automatically sending a claim to a payer automatically like doctors do. So those are all imaginations, but that's already happening today. It's already happening in many states around the country because of all the great work of our team, our partners, everyone together helping us build our own technology with the feedback. And it's already happening today, but it's not over yet. We have to do it a lot more. We're just one small piece of that story. And the good news is, and I miss Amir a little bit, but it sounds like there's a lot of top-down recognition and the waiver is coming any minute? Any minute? Is he still here? But as we move to the next phase of this work, data exchange, standardization, measurement, we have to know the last mile to measure. Everything on the way to that, did the patient get the help they needed? If you don't know, we cannot measure. So to bring it back to the same circle, it takes all of us to do that. It takes technology, it takes funding, it takes systems change, it takes government, it takes all of us to be able to do that. But this stuff doesn't happen overnight. I think we already know that. I'll just end with, and one of our advisors, Andy Slevitt, says this all the time, it starts with one client at a time. And then it's one client every minute of every day. Technology helps with that. You all help with that. Partners help with that. The community helps with that. Now imagine that's happening. We're doing it all together, and we all know that's happening together. That's a very big difference. And feeling that, there's nothing better than hearing a success story about a patient and hearing that together, that we all helped in that, but we all need to be connected. not just connected, but receiving those services, and we know that they're in a better place than they were yesterday. We're on the way, and it's a great sign. I want to thank you all again, appreciate us allowing us to sponsor this, and appreciate everything you all are doing every single day for people in New York. So thank you.
Great. Thank you, Dan, for those thoughtful remarks and your partnership in making this conference accessible. And of course, I want to give another round of applause and thanks to our sponsors, the Commonwealth Fund, Essentra Health, Find Help, NISTEC, Public Health Solutions, the New York Academy of Medicine, and Big Apple Event AV. But mostly, I want to give thanks to you all that are here in person, to you all that may still be logged on remotely. This has been a really dynamic day. And, in thinking about sort of the closing remarks to encapsulate what I think has happened here is I want to take it, Dr. Wang talked about, the 20,000 foot level and the 2 foot level. I want to take it to the 60,000 foot level and really sort of put this in the context of systems. And what I've seen play out today is really that dynamic push and pull when we have systems that are trying to learn and grow and be responsive to the needs of the people that they're serving. On the one hand, we have Medicaid that is incentivizing innovation, and we've heard from the panelists the way in which PCMH has really helped to transform a lot of the practice that happens here in New York City. And on the other end, we've heard of the needs of Medicaid still needing to be even more responsive to the needs of providers that make our systems work. And so that dynamic will continue. And one of the things that I want to sort of really underscore is what Melinda started us on, and is really leading with the people that we're serving in our communities, and remembering that at the end of the day, it's about ensuring that not only do we keep New Yorkers connected to services, and that ultimately, as we've all been underscoring, it's about the collaborations and how working together we can make these systems be more responsive. And I was really what's the word? I'm losing the word, but it struck me of, the clarity with which Amir spoke about the importance of leading with data and learning from what happened with DISRIP, right? And not replicating the challenges that we encountered within DISRIP, and listening to the provider community, listening to a whole host of different communities, and taking that into consideration as we're building the next Medicaid waiver. And I think it's important for us to remember that as stakeholders, it's not just our responsibility to highlight what the potential deficiencies are, but really step up to the plate when things go wrong. And we know that in this next waiver, things are gonna go wrong. But one of the things that really gives me hope is the way in which our state partners, our community partners, academic partners, partners across the spectrum have really stepped up to ensure that whatever Medicaid waiver gets approved is done so with the input of the provider community, the consumer community, and that in having these convenings that UHF has been collaborating with the state around in terms of getting stakeholder input on how we can, in real time, tweak the system so that we learn from the challenges of that first cohort in June that are being recertified, so that we can make it better for the folks in the July cohort and on down the line, so that ultimately our state will stay at the forefront of ensuring that we maximize the number of New Yorkers that remain covered and have access to care. Because at the end of the day, that's what it's all about. And so with that, I want to thank you all again for taking time out of your busy schedules. I want to thank you for your commitment to this work, and I look forward to the ongoing collaborations that will make this a reality. So thank you all very much.